Thank you for joining us for this presentation, Ethics and Jurisprudence for Tennessee Physical Therapy. My name is Jody Goodkin, and I will be your presenter for this topic. I look forward to sharing some of the new information related to ethics and jurisprudence with you during this course. To tell you a little bit about myself, I have been in the field of physical therapy. I like to round it to 40 years, including my education. So I've seen lots of changes and evolutions that I look forward to discussing with you today. This course is designed to meet the requirements for the Tennessee Physical Therapy licensure related to ethics and jurisprudence. We will be covering the Tennessee Physical Therapy Practice Act, as well as the most current general rules governing the practice of physical therapy, and the updated American Physical Therapy Association Guide of Code of Ethics of the Physical Therapy Profession. Our rationale is to discuss legal and ethical practice in the field of physical therapy in the state of Tennessee. Our goals and objectives are aligned to accomplish that. And when you go back to apply this information in the clinic, you'll do so in accordance with the federal, state, and professional regulations where you are practicing. And no conflict of interest exists for the presenter or the provider of this course. The way the course will run, it is a 4-hour recorded lecture, so you can pause if you want to take a break or take some notes at any point in time. We will start out discussing the ethics component of the course for the first 2 hours, and then the second half of the course will cover the jurisprudence documents. Once you're done watching this video, you will go back to our website, cheapceus.com, and you're going to complete that post-test with the score of 80% or higher, and you can retake it if you need to. You'll submit your payment and have your CEUs awarded. We will, throughout the course, be reviewing the course post-test questions, and you'll notice that on several of the slides, there is this icon on the bottom right that says consider this in like a burgundy color. That's to let you know that those particular slides will be helpful when you go to complete that course post-test.
Our topic today, as I mentioned, is ethics and jurisprudence, specifically in the state of Tennessee. So to just start with a brief quote on ethics, it is knowing the difference between what you have the right to do and what is right to do. This is from Potter Stewart, who is a Chief Justice of the United States Supreme Court. And we're looking today about our professional interactions. And those of us entering physical therapy, physical therapists and assistants, we naturally tend to gravitate towards wanting to help people, do the right thing, and have a strong moral compass. So a lot of what we will hear today will be kind of redundant and second nature, hopefully, from what you're already doing. But we will pose some different questions as to maybe how to consider what is right to do. We can't get in deep into the conversation of ethics without first defining ethics itself. The word itself, ethos, means character in Greek, and it has dual interpretations that are a little bit different when you look at it in philosophy versus a little more of a research perspective. If we're looking from more of a philosophical perspective, ethics is what is good for the individual as well as what is important and appropriate and good for society. When we look at the science of inquiry and analyzing human behavior a little bit more, ethics then is looking more at human goals, our foundation for what's right, what's wrong, what is our decision making that goes into that process. And ethics are important for us to take some time to consider on several different levels. If we just look at ourselves as people, We feel better about ourselves when we are acting ethically, right? When we're doing the right thing, it makes us feel good. If we're executing actions and carrying ourselves in a way that is appropriate and helpful and respectful to other individuals, makes us feel good. When we come together as a profession of physical therapy, when we are all acting and carrying ourselves in that same way in patient care, it increases our credibility with the public. It's going to increase the public trust in us as a profession and contribute to our quality of care. If we go further and look at organizations, our larger healthcare systems, when they bring together all the different departments, nursing, physician, radiology, housekeeping, every department coming together, the different individuals that work in those, the different professions coming together, organizations realize that over time, when you adhere to ethical standards, it is good for business. And they've proven that those businesses perform better over time when there is a high value of ethical and appropriate behavior to increase public trust, and it loops back around to success in that industry. You might be wondering the difference between ethics versus morals, and I'll tell you, coming from a science perspective, the first little bit of this topic, I'll be honest, is a little difficult for me. It's kind of like philosophical, but we will only briefly review this deep ethical and moral definitions, and then we'll get into more clinical related discussions. So the true difference when we look at the definitions of ethics versus morals, what you want to consider, morals are our actions. So it's physically the actions that we're taking. What do we do? They may or may not be overanalyzed and recognized throughout different cultures and different societies, but they're kind of the publicly agreed upon rules that regulate behavior among a cohort of individuals. So those are the customs, the emotional responses to things. There's within that society the accepted ways to carry yourself and act. This is different from ethics. Ethics are the reasons behind why we take the actions that we do. So those are our codes. They're going to be the supporting the actions that we're taking. So our ethic is we have respect for our elders. So morally, my action that I'm taking is, when my mother-in-law is going to get in the car, I'm opening that car door for her. So that just gives you a little bit difference. Generally speaking, in the public and in society, morals and ethics are utilized interchangeably, but where we're focusing today are on our ethics, and we're going to talk a lot about the reasoning behind things that lead to making the appropriate actions as a profession. When we're working through what are ethical questions, what we need to consider are several different things. We're looking at society as a whole, and ethical questions, when we pose them to ourselves, these are the situations that you're in when you're treating in the clinic or in the home or the school setting, wherever you may be practicing, where you wonder, well, what should I do? What ought I to be doing? How should I be carrying myself? And this is looking at how we should be interacting in our practice. They've actually become very well studied throughout not only therapy as well as other industries and society as a whole, that ethical questions lead to this collective belief system. There are several different theories that have contributed to the development of ethics, and we're going to just take a couple of moments to look at some of them. Utilitarianism is the first theory of ethics. You may have heard of this. It was through the work of Jeremy Bentham and John Stuart Mill. This, if you had to slim it down, it's, for the greater good, or, the needs of the many outweigh the needs of the few. This is utilitarianism looking at ethical situations that arise from a perspective of right versus wrong. The focus here is looking at the consequences. What's going to be the outcome of the different actions that are taken. So ethically helping to determine what is the right thing to do in the situation. So there are many different ways that we can look at this in healthcare. One example is considering the fact that healthcare resources are finite. So let's say there was an emergency situation, there was a large apartment fire, and now all of the patients are being rushed to the trauma center and other centers in the area. When those patients arrive, a decision needs to be made of who's receiving the care first, right? There's only so much blood available in the facility. There's for transfusions. There's only so many bandages available. There are only so many operating rooms and physicians on duty that can be performing surgeries. So somehow in that triage, they have to figure out who is getting the care. And utilitarianism looks at it from the fact that, well, what is best for society as a whole? Given these finite resources, how can we help the most people in these circumstances? So if they're looking at individuals who have burns, they might look at something objectively and say, well, let's look at the percent burn. Given that, regions that are burned, maybe a determination can be made of who has the greatest potential of survival. So utilitarianism should say the resources should be directed to those individuals. May not be the most appropriate individually or the most beneficial for some of those patients who do not receive as much care, but it looks at the greatest good for the greatest number of people. That always doesn't sit right with us in healthcare because we want to help everyone, but sometimes those situations do arise. The societal contract theory, this is looking at things a little bit differently. This theory is considering that Hobbes, Locke, and Rawls said, you know, when individuals decided to become part of society, there was a reason for doing that. There's a reason that everyone comes together and agrees upon these different principles. And it goes back to the idea that individually we have different needs and wants and desires, but we may not be able to provide for ourselves everything that we need. So when we come together as a society, we agree to follow certain rules so that we can reap the benefits of everyone coming together and working as one group. So we kind of give up certain things, we accept certain regulations so that we can benefit from that cooperation as a society. And then how we act, our moral code, is based on that. The deontological or duty theory, this theory is actually in direct contraindication to the utilitarianism theory. This theory is looking more at the individual. It's saying, well, what is best for that specific individual? That you're making your determination on what is ethical action in a little bit more of a bubble, what's most beneficial for that specific person. And here is where they tend to contradict each other. So you can consider vaccinations in this case, because it tends to be more patient-centered. So looking at the individual who may get the vaccination and may have a negative consequence of that vaccination, utilitarianism is going to say, well, that's important because more people are protected by it. Duty theory is saying, well, you know, there's a duty to that one specific individual. And if not obtaining that vaccination for them is the best decision because they may have a consequence that's not appropriate, then we are not going to give them that particular intervention. So it's a little bit different way of looking at things in terms of ethics. Ethical intuitivism, this is kind of gut instinct that when we look at ethical situations that we're in, right and wrong, we generally have a sense that there are certain things we all agree upon are not appropriate actions for someone to take. An example of this would be it's not right to commit murder. Everyone just gut instinct agrees on that. Ethical egoism is a little bit different. This is where everyone is looking at their situation and saying what's best for me. That is their only consideration. They're only doing what promotes their individual best interests. And our final theory is the natural law theory. This theory goes back to the idea that behaviors belong to different species. So we're part of the human species. So if you look at us in nature, there are certain ways that we are going to interact and going to carry ourselves, characteristic behaviors. Because as human beings, we have the ability to reason and that capacity to determine right and wrong. We have this intelligence that regulates our action. We don't just go out and do whatever we want. So we're going to develop, because of our reasoning skills, a certain sense of right and wrong. And then when we act against that, that's where morality comes into play. Virtue ethics are a little more concrete. I think these are a little easier to see from this theory. It lends itself well to how we look at things in therapy and rehabilitation. Virtue ethics from Aristotle looks at that we have certain character traits or virtues that guide our decision making. And when we're presented with an ethical situation, it may hit on one or more of these particular virtues. Some of the virtues that we extol and have to recognize: autonomy is one. This is our right to make our own decisions. When we look at our patients, this is looking at the fact that patients have the right to make their own decisions about their own care. Beneficence, this is looking at how we are tasked with doing good for our patients, doing right by them, getting the most out of rehab for that individual patient. Non-maleficence, we're doing no harm as we are delivering our care. Universality, this is looking at being just and accountable to everyone. And then veracity is another one that tends to ring true in therapy, is where we are going to tell the truth also. So there are many others in there. Those are just a couple examples. Virtue ethics are a little easier, more concrete to see and apply. What we're going to do now is take a moment and look at a couple of review questions. These will end up being on your post-test for the course, but for now, we'll just take a couple of moments. I will pose the question, let you consider what your response would be, and then I'll let you know the correct answer. If you are unsure of a concept, it gives you an opportunity to refer back to the notes or rewind this portion of the presentation, because that's where that information would be reviewed. Again, when the course is over, I'll give you the instructions. You will actually go and complete the test. Question 1. Which ethics theory proposes that right and wrong are determined by consequences? And our answer here is A. Number 1 is A. As we look at applying these different ethics theories to our practice, it's not like you're going to stop when a situation arises and try to pinpoint which theory it is. The way that we more practically look at this information is we have that voice in our head when situations arise that pose specific questions to us. So ethical decision making, when we analyze it, we're going to consider it from several perspectives as whether or not what we're doing is ethical. Is it fair? Is it consistent among all patients and situations? And also, is it legal? To lead to whether or not our actions are ethical. So these are some questions that you can pose yourself to see where to fall in your decision making. When we consider if your actions are legal, this tends to become black and white, that in every state we have our laws and our rules that guide practice, that we are going to look at the legality of what we're doing, and we need to abide by that in our decision making. And sometimes that does make it a little easier if we are tasked with a situation where kind of our heart and our head are fighting a little bit. If there's a law that forces us to lean one way, that'll help us make that decision and maybe sleep a little better at night. Along with that, though, those situations do arise where we do have that internal struggle between legal and ethical. And here's one example to consider, where you might be in a situation where what is moral is not always legal. And here's an example of that. You're walking down the street, and I'm a New Yorker, so jaywalking is not allowed, and you're taking your life and everyone else's in their hands if you do try to do it. But let's say you're walking down the street and you see someone on the other side of the street. Maybe they're having a seizure and they are, almost falling out into traffic. So morally, you're going to think, I need to go help that person. I need to assist them. They're going to fall on the street. They're going to get hurt, or maybe they've hit their head. So they need my assistance. I have to go help them. I need to jaywalk. I need to get across that street no matter where I am to help that person. It's illegal to do that, but you have a moral consideration. What you need to consider, that's more a deontological approach, because you're thinking about that person, that patient-centered, that's it. Look, utilitarianism. What if in your jaywalking, you cause someone else to stop short, and now there's a 5-car pileup behind that? And the bicyclist that was navigating through traffic, now he's been hit also. So now you've potentially caused harm to all these other individuals. So in addition to that, jaywalking was illegal. So like I said, I'm going to pose some ethical situations. What should you do? How should you act? There's always going to be those instances where we just really need to consider all the circumstances, but sometimes legal and ethical makes it a little difficult for us to decide how to act easily, and we have to really consider it. When we're looking at ethics in physical therapy, we do have guides that assist us. The American Physical Therapy Association puts out several documents that are considered the normative standards, and I really want to emphasize here that they are the de facto standard of ethical practice. So whether or not you're a member of the American Physical Therapy Association, a profession as a whole upholds these standards, and this body and what they're putting out there is what everyone looks to for where the bar is set for our practice. So it is something that you're expected to adhere to, whether or not you're a member of the APTA. Are your actions fair? Are something that you also need to consider. Is it consistent among all of the patients? Do you handle yourself in the same situation the same way with every patient? Considering the benefits and liabilities to those that are involved, I'd like to pose this to you. If you work in home care, do you stop on time with everyone? Do you go over with everyone? Or do you have some barometer for changing that? Treating late arriving patients. Do you stay for everybody? Don't you stay for everybody? Do you treat your morning patients different than your afternoon patients if you are in acute care and those late evals are coming in? So we need to really consider that ethically we should be fair to all of our patients across the board and treat them the same way. And then a really good way to think about ethics are, would my actions be the same if they were transparent to others? If you had all these little eyes on you, judging you, would you do the same thing? Because we should always be thinking that way. We shouldn't assume that no one's going to know what we do. That shouldn't change how we act. If we're upholding ourselves to the appropriate ethical standard in our profession, our actions should be the same whether or not others are aware of them. This is not a situation, what stays at grandma happens at grandma stays at grandma's. The kids are eating ice cream for dinner and mom and dad don't need to know. That's kind of inconsequential unless the child has an allergy or diabetes or there is some bigger cause to consider. In therapy, we can't think that way. We really have to be aware and uphold ourselves the same way, because a lot of times we are practicing not in view of others, and we can be a little more remote and disconnected, but we need to remember that we're part of this profession as a whole in terms of the expectations of practice.
The RIPS model is another tool that's utilized for that ethical decision-making process in physical therapy. It stands for realm, individual, process, situation, model of ethical decision-making. This is a framework that we're utilizing, again, to help us think out all the different aspects of these ethical situations to determine our course of action. The broad reaching process is going to first involve recognizing and defining the problem using the realm, individual, process, and situation, looking at where is it happening, who's involved, what's actually occurring. Then reflecting on all of the different facts, the stakeholders, looking at right versus wrong tests. Is there a gut feeling? What professional resources can we look at for guidance? Who can we talk to for helping us make the decision? Then with all that information, you're going to decide your course of action and then take that action and assess and move on from there. Let's take a little bit closer look at the RIPS process and components. First, we're going to talk about what are the ethical realms. So this is looking at the context or level where this ethical issue sits. It might just be an individual realm where it's based on one-on-one interactions between the PTA and the PT, between the patient and the family, between a combination of those individuals, maybe between coworkers at a facility. So it's more that one-on-one situation. An example would be, let's say that you have a patient who's refusing treatment, but the family is pressuring them. And pressuring you as the clinician to push them a little bit harder, where you have that conflict between autonomy and the patient, but beneficence and wanting to do the right thing. The organizational realm is looking, kind of stepping back a little further, a little broader, looking at workplace policies, clinical rules. That might be when you have those clinical productivity quotas, but they're limiting the time that you have to spend with your more complex patients. And you have that pressure between efficiency and quality of care, and you need to decide how to react. And then the broadest is when you're at that societal realm, looking at broader healthcare systems, cultural expectations, that access to public health. Maybe those situations that would fall in this category would be when reimbursement policies restrict, as we've all experienced, how often we can see a patient or for how many weeks we have to work with them, which then does influence our clinical decisions. And how do we do that within an ethical and appropriate context? After you tease that out, the next thing to consider are your individual processes, how you're thinking and going to act ethically. And it looks at your more internal moral capacities that shape your ethical behavior. And we have resources that help us with that. And these categories might first be looking at if it's a moral sensitivity type of issue. For example, where you're noticing subtle signs from the family, maybe that they're coercing a family member into certain consent decisions, where you're looking at some more ethical and issues arising. If you're considering moral judgment and processing those situations that present to you, what's the right course of action to take. Might be an example where, again, you have a patient where it's time to discharge them, and we've all been there. You think that the best decision is for them to go to a rehab facility for more intensive care, but they really want to go home, and they're not going to get as intensive therapy in home care, but the patient does have the right to make that type of decision. Moral motivation types of processing when you're deciding course of action. This is where you're prioritizing those ethical values over different interests that might be competing with that. For example, choosing to advocate for that uninsured or underinsured patient despite less favorable reimbursement that you might be receiving. You'll obviously need to, on all of these, look at other implications. That's just one example. And then we have those situations where we really have to muster up our moral courage, where we need to decide to do the right thing despite a risk of feeling uncomfortable or potential other consequences. Maybe there are some unethical billing practices that are occurring in your facility, and despite your fear of workplace conflict, you're going to do the right thing related to those decisions. And those moral courage ones, I can say, I've mentioned my career has been long and I've been in education for a long time. I've had alumni that reach back out to me, particularly with those moral courage ones, where they know what the right thing to do is, but they need that someone to help them just talk it out. And a lot of this is leaning on each other and helping each other in all these situations make the right ethical decisions. And your being at this course is helping you in that aspect. So some examples of specific then ethical situations, you're going to take the problem and try to boil it down a little bit more. You're going to try to classify it to help you make the right decision as to what to do. And everything that we're talking about today related to ethics, we're not giving you the right answer of what to do. It's not a specific yes, no, here's the way to go. It's you need to consider, based on all these aspects of the situation, where you're going to land and what action you're going to take. If it's a specific ethical issue or problem, a concern where something may be ethically wrong, where values are being compromised, would be if you're wondering maybe the specific issue is scheduling really being equitable and fair for all patients, or do you see some getting more favoritism in that scheduling? A dilemma when you have two or more options. That same thing again, respecting that patient autonomy. Maybe that there is a more intensive therapy that's a better option that's indicated, but that's not what the patient wants based on the situation. Distress is when you know the right thing to do, but you're constrained or you're limited. Let's say there's a new treatment that's out, and I have seen this many times, where I really feel it would benefit my patients. I can tell you this happens a lot of time when a new physical piece of equipment comes out, but your facility just can't afford it, or you can't afford to go for the training or the education on that new type of technique. So you're restricted, or insurer rules aren't allowing you to bill for a certain procedure and the patient can't afford it. So it doesn't mean that you don't have other options. It's a distress type of situation, and then that's going to help you decide what questions to ask to make the right decision. And then if you have a situation where there's pressure to act unethically, maybe is that temptation to do the right thing, and then moral silence. Those are going to be the situations where you witness verbal harassment of a patient by a staff member, but you're not reporting it, or you're not getting involved. I'm not saying that's the right thing to do. We're just looking at the classifications, because sometimes when you talk things out or think them out in all these categories that I'm mentioning, it will lead you to the right decision for you based on the situation. And there are instances where legal and ethical kind of overlap, that situations that are unethical conduct, they are frequently going to violate laws and regulations. Things related to billing for services that weren't performed would be fraud. On the flip side, not all ethical violations are illegal. And an example of that might be if you're consistently choosing an easier, less effective intervention. Maybe it's to save time because it is going to work and you're giving the patient more to do as their home program, or because you couldn't afford to go for that training, so you're doing the best you can and the best possible for that patient. Doesn't mean it's illegal. It may or may not be unethical. It just may be the best possible at the time. But if that instance arises where there is a clinician that's trained in that technique and you can collaborate with them, or they work with the patient for that 15 minutes to do the manual therapy technique that you're not skilled on, and then you get them back, that might be an option. So again, just talking out ideas, thinking about clinical situations are going to help you make the right ethical decision. And sometimes you'll come to something that you didn't even realize on your own. I did take some time and look at disciplinary actions common in the state of Tennessee, and this is public record. The most recent disciplinary actions and what was most common. Failure to obtain continuing education requirements is right at the top. Many instances where there are citations and civil fines and penalties assigned to therapists, practicing with an expired license. Clearly, these things are unethical as well as illegal. Failure to perform services that are documented in the charts. Those are all clearly illegal and unethical. I think we can all agree on that. There are also opportunities where we can support each other. Hey, we know renewal's coming up. I'm taking this course this weekend. Why don't you log on with me? Or let's, during our lunch break, let's hop on and complete this text-based course or whatever it may be. Opportunities to avoid those things. Some others that surprised me a little bit that I have seen recent listings of are engaging in performance of substandard care due to ignorance, incompetence, or deliberate neglect act resulted in suspension of license, practicing with physical, mental condition that impairs skill as well as safety, and then also failure to adhere to ethical standards of the profession. And the failure to adhere to ethical standards of the profession, that's where we're focusing today, on all these broad-reaching foundationary things. What we're going to look at to guide that ethical decision-making, and this is new in 2026, the American Physical Therapy Association Code of Ethics for the Physical Therapy Profession. They've merged into one document, the standards and expectations for PTs, PTAs, students, for all physical therapy professionals. And it defines those ethical expectations and gives us guidance for when we are facing challenges across all different settings. It lets the public know what we aspire to as clinicians, and then it gives us that accountability for how we should be practicing to put the best foot forward for our profession and make the best decisions for our patients. We're going to take time to tease through all of these and discuss them individually. They do note in the Code of Ethics that the document cannot be exhaustive, that it does provide a foundation for decision making, but you need to recognize individually when additional guidance is needed. And you may get that from many different sources. You can look at guidance from just your colleagues, from your professional resources. In some instances, you may need to seek out legal counsel to make your decision. Know that the one document by itself is not going to tell you exactly what to do. You're still going to use your judgment. And as we guide those decision-making and work through the new Code of Ethics, they structure it in a specific way. We have these broad-reaching foundational principles that we will look at first, and those are kind of our pillars for our ethical decision-making. It's kind of that background agreement we all have on what's professional, appropriate, ethical concepts and ways of thinking, those morals. Then from those, the APTA has developed ethical commitments that builds on the principles. It's a specific statement that says, hey, this is what we hold ourselves to. And then they break that down into the standards of conduct. Well, this is what we physically expect to see our clinicians doing and not doing. And then lastly, they will give some specific aspirational examples of applying those concepts, and we'll talk those out also. Those ethical principles or pillars of ethical decision making that kind of sit in the background of all the decisions and thinking that we're doing. First one is going to be related to autonomy. This is looking at confidentiality of records, the patient's right to make decisions about their life and their body. Beneficence, considering clinical decisions that put the patient's best interests first, that you are going to consider being kind and compassionate. And I think these all are going to sound so obvious to us because we enter the profession. These are the traits that pull us to this profession, and being excited for our patients' successes and frustrated when they have frustrations to find a better option and more to do for them. Non-maleficence, avoiding harm. A sense of justice, being that fair and equitable, objective across all of our different patient populations, honoring their dignity. Veracity, of being honest, transparent with both our internal and external parties that we interact with, and then having that fidelity in everything that we're doing for all individuals and populations, upholding respect and integrity. Another guiding document that can help us in our ethical decision making is the APTA core values. This is for the PT and the PT assistant to help guide our safe, effective, and evidence-based care that we're providing. First, let's talk about accountability. When we talk about accountability for the PT and the PTA, we own our own actions and decisions and the outcomes that we're creating. Being accountable means that we're practicing within our role and we're following supervision guidelines and making those decisions that positively influence the patient and their outcomes. Altruism reminds us that our patients come first. That's why we are here, why we are engaging in the activities that we're doing. So that ethical practice means placing the needs, goals, and well-being of that patient ahead of things like convenience and productivity or personal gain. Collaboration is next. It's central to physical therapy. We're collaborating with patients, families, other healthcare providers to reach those shared goals. And ethical care is going to happen when that communication is clear and everyone's roles are respected. Compassion and caring. This is going to guide how we treat people, right? It's how we interact. We show empathy and respect and understanding for each person's and patient's lived experience. We're recognizing that human side to the care that we're providing. We know that that patient is not just a diagnosis, and we keep this in mind in all of our interactions. Duty reflects our responsibility to provide effective care, support our profession, and also contribute to the health of society on a larger scale. This includes being prepared for the practice that we're doing, making sure we're ensuring safety, advocating for the patient when needed, all of those different aspects coming together. Excellence, of course, is what we are striving for in our profession and everything that we do. This means using the best available knowledge, include that patient and family perspective when we can. And we're going to challenge mediocrity is the way that the APTA phrases it. So we're looking at that lifelong learning, recognizing our own limitations and seeking assistance or referring out when necessary, and really committing to that personal improvement for the betterment of our patient and the profession. Inclusion. This requires us to create a welcoming and equitable environment. Ethical practice means recognizing bias and promoting an environment that does not engage in it, while promoting safety and ensuring that all patients are going to feel respected and valued while they're receiving our care. And that really ties in with integrity. It brings together everything that we are doing. We act ethically, honestly, fairly. We're going to follow through on these professional commitments that we're making. And then lastly is social responsibility. This reminds us that physical therapy serves beyond that patient that we're treating, that we have a role in society at large in promoting health and wellness and building that trust in the public, in trusting our profession to come to us for their care. Question 2. Physical therapists and physical therapist assistants demonstrate the APTA core value of altruism when they B. Place the patient's needs and goals ahead of personal convenience. So 2 is B. Place the patient's needs and goals ahead of personal convenience. Question 3. Which of the following statements is true? Three is D. 3 is D. Four, which of the following is not one of the stated purposes of the APTA's Code of Ethics for Physical Therapy profession? Four is B. 4 is B. As we look at the APT Code of Ethics for the physical therapy profession, the specific ethical commitments fall under the categories of respect, integrity, accountability, maintaining professional relationships, compassion and trust, responsible business and organizational practices, direction and supervision, professional expertise, and societal responsibility. It is broad reaching as we consider ethics because we know in our delivery of services, we do more than just treat impairments. We're influencing the dignity, identity, and quality of life of our patients. We're having a significant impact. And every clinical decision that we make, it has an ethical dimension to it, even when it's not as obvious to us or we're automatically falling on the side of making the appropriate decision. So we're going to go through each of these specifically. And as we look at the terminology that's utilized trying to decode the professional expectation language, I'm going to take us back to preschool when we say, "Can I go to the bathroom?" And the teacher says, "Yes, you can, but no, you may not." Right? Can and may. Can means you're able to do it, capability. May means there's an optional permission there. It's at the discretion of the individual. When we look at these different ethical expectations, we're up here at this higher level. And the word that we're going to see utilized in the statements from the APTA is shall. This is looking at more of an absolute requirement. It is a little more legally enforceable. It's the historical equivalent to must, which is an absolute statement that we often see in laws. These statements really aren't down here at should or recommended, because in that usage of that terminology, it's a strong expectation or just a suggested advice. So all these statements are going to be shall statements because it is what we should be. See, I did it right there. They're shall statements because it's the actions that we're expected to be taking. First one, the ethical commitment. On all these slides, the way I have things formatted, the ethical commitment is going to be this top pink statement. That's the broad reaching statement. So number one, related to the aspect of respect, is that physical therapists and physical therapist assistants shall respect the inherent dignity and rights of all individuals. Within each of those, they then go down and they have the specific standards of conduct. And that's what I have here, that's in the black print as we go through each slide. And then that's going to be to not discriminate against any person, to protect patients' rights, confidentiality. As we look at respect, following the appropriate laws, that's following HIPAA. As we go through the presentation, I'm going to use this same formatting. The statements as I have them written are adapted from the APTA Code of Ethics for the Physical Therapy Profession. There's shortened versions and wording of it. You should look to the reference that I have here on the bottom of each slide to read the full statements. After we look at that broad-reaching ethical commitment statement that I have in the pink, then we look at the standards of conduct, the actions that we're going to be taking. That'll be in the dark font on the first slide for each of these. They also provide these aspirational illustrative examples, and this is more looking at what we're striving to do. And those statements will all have shall strive to acknowledge and respect the individual's identity and culture, for example, for this first one related to respect. As we look at that, this is considering that we are looking at our cultural effectiveness. And interestingly enough, the research in physical therapy interaction, some studies found that we are not as culturally competent as we think. And they do suggest that we look at some client-centered feedback on that, peer reviews and observations of our performance to see if we really are as culturally competent as we think we are, and sensitive and aware. Another component of this is to look at our explicit and our implicit biases that might be impacting our clinical judgments. Those specific biases, explicit bias, that is going to be those situations where we're aware of a conscious bias, that we recognize that this is something that we're thinking. Doesn't mean it's right. We shouldn't be doing it. An example might be you prefer to work with male patients because you perceive that they work harder in therapy, or you don't want to work with patients whose payer is through workers' comp because you think they'll be more likely to be malingering and not putting an effort forth. Those types of explicit biases, those are going to undermine the patient's rights. It may lead to unfair prioritization or deprioritization of certain patients. So we want to acknowledge and address those. Implicit bias, on the other hand, this is a little more unconscious. We may not be recognizing that we have these beliefs. It is something that we need to maybe have others tell us, or step back and take a moment to question ourselves and look at our actions about, because often they unintentionally shape our expectations for patients and how we interact with them and communicate with them, and can impact the quality of care that they receive. For example, you may look at your elderly patients and say, give them less challenging exercises because you don't think an 80-year-old is as capable. Well, I can tell you, I've worked with 80-year-olds who are still running marathons, and I can barely run to the corner. So they are definitely more capable and can probably handle a more rigorous aerobic program than I can. And we know these things. We just need to recognize it sometimes in ourselves to be aware of it, so it doesn't impact our practice. The ethical commitment 2 relates to integrity and responsibility to fulfill our legal and ethical obligations. The focus here is that the PT maintains the responsibility for all patient care, all aspects, evaluation, and management. And in my paraphrasing of these statements, if I specifically indicate PT or PTA, that means in the original document from the APTA that it referenced it that way. If the statement, for example, the rest of them 2.2 and 2.3 do not indicate, that means those statements are referencing the PT as well as the PTA. Just a little formatting that we went through there. We're going to get consent from our patients as part of the integrity that we're maintaining with them. And then we do want to be aware of the reporting guideline here, that if we have colleagues who, in your reasonable judgment, that you have a substantial question that they are unfit to practice competently and or safely, that you do need to look at reporting that. And that may take different shapes. If you have a colleague, I've been in a situation where someone's diabetic and they're maybe getting a little shaky, but they're still providing the interventions competently and appropriately, but you're like, wow, their blood sugar's low. Maybe they didn't take their lunch break. You step in, talk to them, cover for them, and they can go take care of that. That may be just addressing it with them. It doesn't mean you need to escalate it. Versus if you have that colleague that's coming in every Monday morning and they appear to still be hungover or impaired, and they're not guarding the patients appropriately, and you actually need to step in and assist with that to maintain safety, or you're not sure about something, where then you're going to escalate that through either your institutional policies and possibly take other actions. How you're going to report and where you're going to report may be different based on the situation, and that's where that RIPS process comes in for you to figure out what direction to go. Continuing with looking at integrity, we're going to again address those illegal and unethical acts that we see happening. If we have any mandatory reporter obligations, looking at children or vulnerable adults, suspected abuse or neglect or exploitation that's occurring, we're going to follow the policies, procedures, and laws related to reporting those specific situations. And then we're getting a lot more involved in research with evidence-based practice. So we want to protect our patients who are also participants in research. When we have that dual role of being the researcher and the care provider, we want to make sure that we're prioritizing patient care over those research outcomes. We need to disclose to our patients that dual role and ensure that their participation truly is voluntary. Our aspirational and illustrative examples provided related to integrity are looking again at that misconduct, that we are making reports of known illegal or unethical acts that are related to verbal, physical, emotional, or sexual harassment, and that we're demonstrating integrity in our relationships with all of our stakeholders. And we're going to take action to address any potential illegal acts at all different levels. And these all statements are going to apply to patients, families, other providers, employers, payers, the public. We're going to make sure that we're holding our highest standards of integrity in our interactions. Looking at accountability for standard 3, this is making those sound professional judgments, practicing within the laws and regulations for our profession. We need to reflect on ourselves as well as others when we look at making appropriate decisions, particularly looking at when to refer patient to another healthcare provider. If something's not within your skill set or your ability, it's okay to refer them out or have them work part of the treatment with someone else because it's the right thing to do. If you have a situation where there is no one else to refer them to and you're doing the best you can for that patient, that may be a different situation. As we look at practicing without impairment from substance misuse, cognitive deficiency, or mental illness, it's important that even when there are appropriate accommodations or reasonable accommodations that are provided, if it adversely affects practice, this is something that should not be occurring. And again, sometimes we need to look at ourselves relative to that, as well as keeping our eyes out for what's happening around us with other providers and make sure we're complying with any laws related to those safety concerns that may arise. This accountability is going to extend to looking at our judgment in making our clinical decisions. So the PT is going to demonstrate independent judgment and make decisions in that client's best interest, making sure that we're using evidence in doing so, as well as our experience and knowledge. And then PTAs are going to do the same thing, specifically in consultation with that PT, because they are working under the supervision of the physical therapist. There's several instances in these standards where it references accuracy and truthfulness in disseminating information, and it goes on to clarify that with making sure that this truthfulness and accuracy occurs in information we're disseminating directly with the patient, as well as through emerging technologies such as social media or AI. And I read an interesting study where they were looking at different posts from physical therapists, and they found that in only 14% of the posts they look at, it was well over 1,500 posts. They found that only 14% cited some kind of reference, and 57% demonstrates some type of conflict of interest. And this is important for us to recognize that we don't want to overstep with our patients and compromise that trust. We want to make sure that they're making their decisions based on genuine information, and that we are making our decisions not based on a benefit for us in some other format. And as we're looking at information that's posted, that we ourselves are using our clinical judgment to look at who's the source of that information. Is it accurate? Can we utilize that information appropriately in our practice? Maintaining professional relationships. In this particular statement, this is very clear what is indicated, that there is not to be engagement in sexual relationships with patients, clients, supervisees, or students. It is a broad-reaching statement that they have here, also on not engaging in any type of harassment, verbal, physical, emotional, or sexual. And this statement, the way that they have it written, it is with any patient, client, supervisee, or student. It does not say current, it does not say former, it does not clarify that. So there is a situation where you as a clinician need to consider, is it appropriate to engage in a relationship with a former person that you had a professional relationship with? Continuing looking at that statement, you're not to enter into or initiate any sexual relationship. We are looking at not impinging upon the integrity of the provider and patient relationship. We want to make sure that we keep that relationship trustworthy and empowering patients so that they can engage with us with clear thought on the information they're given to make clinical decisions for themselves and their quality of life and functional abilities. Taking a little bit closer look at these statements related to the therapeutic relationship, the PT provider relationship is foundational for everything that we're doing with our patients. And they are vulnerable populations that we're working with. Just because they're coming to us, they have some type of physical limitation. Their emotional state is not necessarily at its typical baseline because of everything they're going through. They may have psychosocial challenges that are occurring. This is the perfect storm for misinterpretation of our compassion, of our therapeutic touch, and it could potentially lead to some clinicians taking advantage of patients or patients misinterpreting and thinking there is more going on in the situation. And that change in the power dynamic, we really need to be cautious of. We cannot impact our clinical decision making because of these different relationships that are developed, where there might be sexual misconduct, there might be some harassment that is starting to occur. This can take many different forms. It could be physical touch, it could be flirting, dating, even socializing online or outside of the clinic. Is that appropriate with students? If it's compromising the relationship, the power dynamic, the reputation and the trust. Think about the trust in several different ways. If that other individual, let's say a patient, has a bad experience when that relationship ends, that may lead to distrust for them of all healthcare professionals that can impact them. For the clinician, what happens to their reputation? How are other professionals going to view them? How are potential patients going to view them? And then that can all impact the workplace dynamics with the other clinicians, which can impact an even broader base of the therapists. This can further impact the employer if they are going to lose potential clients now because a relationship ended badly, and now there might be negative reviews online or a reputation compromise for the clinic. So there are lots of reasons that the ethics go into not engaging in these relationships, and where you as an individual have to look at every situation that could potentially be harassing or involve sexual misconduct, and consider all these different aspects to make the right decision as to whether or not it's a situation you should be engaging in. Continuing with maintaining professional relationships, we are going to promote inclusive work environments where everyone has a sense of belonging. And then we are going to take care in supporting our colleagues who are facing physical, psychological, or substance-related impairments that may adversely impact their professional responsibilities, encouraging them to seek assistance. And that clinician impairment is a complex issue. We need to look at it relative to ourselves as well as the other clinicians that are around us. Clinicians need to function free from impairments of cognitive deficiency, substance misuse, or mental health issues that can cloud their judgment and compromise that safe, ethical care. When we look at some of that, again, it overlaps with legal issues. Focusing more so now on the ethical component of that, I don't know if you've ever heard the saying, you can't care if you aren't there. That self-care is really important, and we give so much of ourselves in this profession that we need to take time to seek out help for ourselves or encourage others to look at counseling or other appropriate support. If you're experiencing fatigue, stress, burnout, it's been called so many different things over time. Maybe someone is undergoing medical care themselves, and it's stressing their body and their mental health and their ability to deliver services to the patient. We do have an ethical duty to report if a colleague cannot practice safely and competently. But before we get to that point, there are probably opportunities for us to intervene early on to support them in different ways so that they are able to continue to deliver safe and competent care. Self-awareness is important as we look at ourselves. Maybe you have a new baby, so you're not sleeping as well at night, and the mornings are a little bit tougher for you. Possibly you look at shifting your work hours then, or maybe you can schedule things differently so that you have your patients in the morning where it's not as rigorous and demanding, and you're able to competently and safely make decisions for them, and then you're more complex later in the day, as long as that works for those particular patients. And then you might have those situations where we've already said where something is just beyond our expertise and our skill set, and we're going to feel comfortable referring them to someone else. This is particularly important for physical therapist assistants when you see something in the plan of care that you don't think you're going to be able to accomplish, that you do communicate that with the PT and come up with alternatives on how to manage it. Ethical commitment and standard of conduct 5 relates to compassion and trust. This, I think, is pretty straightforward. There's nothing really new here that we're not already aware of. Being truthful, accurate, with relevant information for informed consent, address barriers to communication and comprehension. We're going to present those exercise programs if our patient has challenges with their reading level, maybe in a visual format. With technology now, certain patients, maybe they need more verbal demonstration or a recording of how to do things. We're going to be aware of communication and comprehension barriers and then adjust so that we are able to get the message through to our patients to deliver comprehensive care. The examples provided by APTA are demonstrating care with compassion. I think that's instinctive for us, even on a bad day, right? We're usually sacrificing ourselves for our patients. Well, that's something that we do need to be aware of, that we need to keep ourselves in a good, healthy place also. We're going to be truthful in all forms of our communication and maintain that public trust. Again, here they mention that this is in verbal, written, nonverbal format, and also social media and AI. To take a minute to address social media, because it does come up so many times in these versions. Again, dating myself here, I have to honestly say that computers did not exist when I was in PT school, fresh out of high school, back forever ago. And when they did at the end, it was just a glorified typewriter. That was really all that you can do. So I come from a different generation and I've seen all of this grow. There are so many more things to consider, great opportunities, but a lot to be aware of. You need to consider the sources of information, like what you're putting out there, but also what you're reading and using, and knowing that our clients are going through that. Again, I come from the days where if we wanted to know what was new and current or what's changed, we would have to get ourselves to the library, go through a card stack to find the resource, then go pull out this microfiche. It was a little film you ran through a feeder to look at a image copy of one physical copy that existed somewhere in the world of a research article. Nowadays, everything is so instantaneous, but we have to make sure that things are still evidence-based, that if we're posting things, we're giving disclosures to individuals when we're disseminating information about using it, appropriately, and consulting their healthcare provider if necessary. Make sure that you're identifying your credentials. This falls under the legal aspect also, to identify yourself appropriately. Separating personal and professional accounts. Remember, deleting content doesn't mean that it's gone. It doesn't eliminate risk. It may still be out there. In terms of patient information, we have to make sure that we have permission for what we're posting related to that confidential information. Consider testimonials, videos, even replying to both posts. Do you have permission, or should you be acknowledging that someone is or is not your patient even? And then we can look to our professional organizations and standards for a lot of these things. The lines are definitely blurred. In my day, for example, with students way back when, the biggest concern you had was, can you end up at the same restaurant with them having a meal? Now today you're looking at, if you friend them on social media and maybe they're posting pictures eating a bunch of ice cream, and you might happen to reply to that post and say something to the effect of, oh, swimsuit season's coming, remember? Or you do a hit me up for an exercise program. Probably not really appropriate to be doing that. It can alter that dynamic and that relationship, and things need to be considered. The same could be true if it's a vendor or a physician who's a referral source or a patient. So there's a lot of things to consider when we look at social media, to be aware of. Artificial intelligence is the other area that is completely changing healthcare. It's important to recognize that AI is not held accountable for the ethical responsibilities that we assume as healthcare professionals, that we need to really show responsibility in this innovation. And it's really important that we recognize that AI is moving towards augmenting our practice. It is not autonomous. We must interpret and use judgment with it. And as we look at that, there might be good opportunities where it is beneficial to support different aspects of outcome tracking, decreasing administrative burden, with documentation, scheduling, data analysis, things like that. It's not going to replace clinician judgment. We do have resources that are coming out, starting to look at how can we safely and appropriately start using AI. The ethical risks that we have to be concerned about relate to bias and fairness, that results can be skewed based on the different inequities in the data that the AI is using. The outputs, they may show unequal recommendations for different population sets. It's really a tool, not a provider, and we have to remember that. Also think about data security of what we're putting in there, and those terminology of what we're seeing now emerging, those black box decisions that come from AI, where it may recommend different approaches, strategies, treatments, things like that, without a true explanation or giving an understanding or reasoning behind the why. Or when you look at the resources it pulled from, those are not evidence-based and appropriate, which again is where we get back to the clinician still needs to play an integral role in using this, and we're figuring out how it can be done ethically and appropriately. Back to something that is more black and white related to our ethics, when we look at principle number 6, responsible business and organizational policies. We're looking at, again, being accountable, being truthful in our business practices with our appropriate documentation, disclosing conflicts of interest that may exist, not accepting gifts or other considerations for influencing or making different decisions. Continuing with that, if you do have any financial interests when you're recommending services or products, you do need to disclose those to your patients. Make sure that, again, in social media, are you endorsing products? Are you disclosing different partnerships that you have? If you're using, even in the clinic, a particular piece of equipment, do you say, oh, we used to say, oh, the rep is letting us borrow this piece of equipment to test it out. Do you want to participate? with this. Or, if you're recommending to your patient they should have an exercise band to do their activities at home, are you telling them a specific brand of product and store to go to buy that? Or even a specific online provider to go to? Could that be perceived? Are you getting some kind of kickback or some kind of benefit from that, especially if you do have that connected to social media? Or are you generally saying, you should have an exercise band of this strength or this color, and the brand doesn't really matter. You can go wherever to get it. These are things that we do need to consider in how we're presenting it to our patients and clients to avoid any potential conflicts of interest there. Also, we want to recognize that we want to inform patients of financial obligations in advance of treatments if something is not going to be covered by their insurance. Let's say hot pack is not going to be covered, but you think it would be beneficial before the stretching and the exercise. You need to present that to the patient, let them know what the fee may be, and then present them with that alternative. Or we could do active exercise in this way and make that a partnership in some of your decision making. And I think these are things that we're already doing in a lot of these ethical discussions. I'm just hoping that you realize I know that you're just giving me the head nod that, yes, I already know this and this is what I'm doing. Looking at the aspirational practices here, this is continuing with being truthful, being ethical. Number 7, under direction and supervision, we are recognizing that the PT is working within their scope of practice and delegating within that, and that the PTA is working under the direction and supervision of the PT, and they are communicating patient status that may necessitate changes to that plan of care. And that's a two-way street. The PT also has to make sure that they're available for that communication. And oftentimes you're going to look to your practice act and your general rules of practice for specific criteria related to that. PT maintains that primary responsibility for supervision of the PTA as well as the support personnel, with the PTA recognizing and respecting that relationship and supervision. And the key here is that the PTA also is going to, in a timely manner, communicate, as we said, anything about safety and effectiveness of practice back to that PT. If the PTA, you are reading that evaluation and the plan of care indicates lymphedema, treatment through lymphatic massage, and you're not trained in that, immediately would be the time to let the physical therapist know that. Or maybe kinesiotaping is in the plan of care and you're not comfortable with that. Whatever it may be, we are going to, again, communicate. And as a PT, you need to make sure that when you are delegating things, it is within the scope of expertise. Continuing with that direction and supervision, we're going to mentor each other. We're going to support each other in our learning and how to expand our practice. That leads us directly into this professional expertise. We are going to look at career-long acquisition of different skills. And we're going to be humble. Again, if something is not within our skill set, or we have that openness to recognizing our limitations so that we can do things within the best interest of our patients. Maintaining competence as we look at emerging technologies. Just to give you a couple of examples from my career, when I look at emerging technologies, I think back to wound care, for example, where we started out with full body whirlpools, regardless of where you were trying to treat, whether it was that sacral decubitus or some other other area. Then we moved to when we had portable extremity tanks that we could wheel to a patient's bedside. That was huge. Moving on to the Pulsavac, where you could do bedside lavage, and then the negative pressure wound therapy. And now we're looking at, well, we transitioned in between there to hyperbaric also, now bioactive wound dressings. It is amazing. Without continuing education and continuing competence, how would you ever keep up? I could give you other examples. Just looking at prosthetics and the changes. You used to be there side by side with the prosthetist and your screwdriver, Velcro, and straps to hold on that prosthetic. Or I got my sewing machine out for that transfemoral prosthesis to make an extra little like girdle to try and keep it up before we had neoprene sleeves and the different types of silicone systems and ratcheting systems. And now we're at the point where we have implants that are being utilized. So it is amazing and exciting and all of that. And it's part of our ethical obligation to stay current with that and self-reflect, to look at that information. And we need to be mindful, as we know, that we're looking at the evidence and applicability when we go to implement that into practice. We're going to cultivate environments that support this for each other. And we're also going to remember to help each other maintain our mental, emotional, and physical well-being. As you look at enhancing your expertise, you're going to engage in continuing competency through that self-reflection, identifying your weaknesses or new skills you want to acquire, and then going ahead and developing those skills. There are so many different ways that you can expand your clinical expertise. It doesn't always have to be an intervention. At this point in my career, I of late have been attending more types of continuing education related to different body systems, and that emphasizing that collaboration aspect that's discussed a lot here in the ethics. For example, a gastrointestinal conference, a national one I attended, a surgical conference. Am I doing surgery? No. However, it gave me more awareness as I look at potential red flags for patients related to those conditions. By understanding the surgical procedures and the postoperative recovery, I can see if a patient has that in their medical history, how that may impact whatever physical therapy diagnosis I'm seeing them for. And it just, I felt, made me a better, more well-rounded clinician. So you can look at expanding your clinical expertise in many different ways. And that kind of brings us to societal responsibility, which is the last item that we are covering here. When we look at societal responsibility, we are going to look at providing resources for individuals who might be in harm's way. We're going to make sure we're maintaining patient safety in that respect. Referring them to outside agencies as necessary. Community resources, if you have that patient with diabetes who the wound is not healing, they can't get to the store to get their food, maybe they're spending all their money on doctor's visits and bandages and dressings, and they have food insecurity, you refer them to a community resource that can assist with that, or a dietitian consult that maybe there's a way through their insurance they can get some additional support there. We're looking at ways to expand our practice in order to advocate to reduce health disparities and expand access to care. I mentioned looking at collaboration opportunities. This is where we look at getting into preventive medicine, aspects of expanding that scope of services. which can also be in the form of delivering pro bono services to those disadvantaged, underinsured, or uninsured populations, and trying to look at advocating expanded use of physical therapy services and scope to benefit the community at large. As we look at all these different aspects from this new code of ethics for the physical therapy profession, we're going to hold ourselves to this high standard. And if we do have ethical concerns that we need to address with others, best practice is, when possible, to address it with the individual. Gain factual information, address what you think might be going on with that specific individual, and then if need be, go from there in terms of looking at corrective steps within the organization, or if you need to report misconduct. Question 5. It is unethical for a physical therapist to engage in a sexual relationship with their. 5 is D, all of the above. 5 is D, all of the above. Question 6. Physical therapist assistants shall provide physical therapy services under the direction and supervision of a. 6 is A, physical therapist. 6 is A, physical therapist.
Let's take a look at medical necessity. So we're going to discuss a little bit about how we make those decisions based on patient care to see if it's being delivered in an ethical manner. So our situation is Steve is a physical therapist and owns his own therapy clinic. He recently signed a contract with an HMO to provide physical therapy services. The contract stipulates that Steve will be compensated on a case rate basis. So this means a fixed amount of money per patient based on their diagnosis. Steve has performed a thorough cost analysis on this contract and has determined that the financial break-even point, the revenue equals expenses for his practice on each of these patients, is 5 visits. He informs his staff that all patients covered by this insurance must be discharged after their 4th visit. Is limiting care in this manner considered ethical? Let you ponder that for a second. Should be a pretty quick decision making for us. So a couple of points for you to consider on this case is that physical therapists and assistants are obligated to propose treatments to our patients, that we have to have a sound medical healthcare rationale, putting the patient first and being equitable in that. And we're using sound judgments when we're deciding patient care. So based on this determination, do you think that there is potentially a conflict here of interest? Do you think that that care was ethical that was being delivered? Most definitely not. It wasn't, because the individual is demonstrating decisions other than the needs of the patient in terms of making their decision on when to perform the discharge. So we shouldn't be delivering our care in that particular manner. Let's take a look at another case study. So you work in a very busy outpatient rehab clinic. One of your coworkers is a physical therapy aide who has worked in rehab for more than 20 years. Frequently, she is called upon to perform treatments that should be done by a PT or PTA. The patients always give her great compliments, and she frequently, they are requesting her for treatment. She demonstrates exceptional skills and achieves outstanding outcomes. Is the clinic providing ethical care to these patients? Couple of key points to review on this case: that it's each PT and PTA's responsibility to adhere to the standards of care for licensure also, but they also have to make sure that the care that they are providing is appropriate and within the scope of practice. So in this case, is the patient providing ethical care to these patients? Not the case. That with the aide treating patients, that is not within their scope of practice, that is not the best and most appropriate individual to be performing the services. And then we can even spill that over a little bit into legal consequences for those individuals, depending on how they're billing for those services. So when delegating interventions and tasks, we need to make sure that it is within the scope of practice, the best interest of the patient, and who has the most appropriate skills legally and ethically to perform those interventions. The first one is consent. When we look at consent for our patients, there are a couple of different types of consent. We have consent for multiple treatments, and then there's blanket consent, and then there is just consent for the treatment that we are providing to them. When we think of consent, most patients think of that stack of forms that they receive when they come in for therapy, and right, a lot of them are just signing them. We need to think a little bit more about what is consent and why we're doing it to make sure that we are thorough and ethical in its execution. Informed consent specifically is looking at an explanation to the patient of what are we doing for them? Why are we doing it? What do we expect out of these interventions? It needs to be specific to the patient as well as the clinical situation and the plan of care for that individual. So initially this happens after the physical therapist evaluation. We're going to mutually set goals with our patients. We're going to discuss what type of treatments we're going to utilize with them throughout therapy. What do we think goals they can and can't achieve? What's realistic? And then specifically with informed consent, as we carry out our different interventions, we're going to give them the rationale for every treatment technique that we're going to do, right? You don't just tell your patient, okay, I want you to flip over on your stomach now and move their leg, and then flip over on your back and move their leg, and then stand up and say, okay, just walk. No, we add more to that. So we kind of thread informed consent throughout and get that okay from the patient also. We'll say, you know what, now we're going to do some stretching for your hamstrings. Or let me stretch that hip out for you. Or now that we have some strength in your leg, let's practice walking. So you're probably doing these things and not even thinking about it as contributing to your patient's informed consent. And it's important that we do that. What we need to recognize with informed consent is that we're not specifically looking for agreement on the plan of care. So when you're executing informed consent, you're giving the patient information. They can choose to follow it or not. That patient may say, when you say, okay, now we're going to stand up and walk, now that we stretched your legs out and did some exercises, they may say, no, I don't want to walk. So that you gave them informed consent, you're telling them, well, you know, we need to put the exercises together now. Now that the muscles have developed some strength, we need to work on your coordination so that we can get you walking to get you, you know, to be able to go to the restroom on your own. That's the informed consent part. Them actually agreeing to participate is not. So we're looking at what our duty is to give the information to the patient that they need to make the decision about what they want for their care. Where we need to consider specifically are patients who are unable to provide informed consent on their own. So your pediatric patients, your patients with dementia who are not consistently lucid, your patients who are in a coma, that you might have a reasonable person or a surrogate that is able to give that consent for the individual. So they may be part of these conversations. When we look at giving our patients the information that they need, informed consent has several different components. We're going to not only tell them what treatment we would like to do with them and why we want to do it, we should propose some different alternatives and why we are not recommending or choosing those. Any risks that the patient may incur or negative consequences that could occur from this treatment. We also want to go over with the patient the prognosis in terms of achieving their goals, and we want to take some time to maybe emphasize the consequences of non-treatment. And that's a good one when you have patients who are not compliant or refusing therapy. You might want to make sure that you were appropriately explaining at a level that they can understand what are the consequences of non-treatment. We want to also make sure that our patient is actually understanding what we're saying. There's a technique that's out there to make sure that you hit on the key aspects of informed consent, and it's called the PAR-Q. So PAR-Q, the P in it is saying you are going to tell your patient the procedure or the technique that you want to perform with them. The A is looking at you are going to tell your patient the different alternatives that are available. The R is you're going to explain any risks that might be associated with the treatment that you're performing with them. And I like to add to this another R. You're giving your rationale for why you have suggested what you have to achieve their goals. And then the Q is making sure the patient doesn't have any questions, so alleviating any concerns that they may have. So what you want to make sure you accomplish overall with informed consent is giving all the information that any reasonable person in a similar situation would need to make their decision. And ultimately, getting that consent is not part of the informed consent. It's the giving of the information. Consent for multiple treatments. This is when someone is involved in treatments that have multiple segments to them. So for example, someone who's going for chemotherapy, they may consent to that chemotherapy and there'll be multiple visits that fit with that one consent. That's different than, let's say, someone who maybe they need a blood transfusion after their surgery because their platelets are low and they're anemic, and they have the blood transfusion that they consented to, 2 units of packed cells. That doesn't mean if their labs have not improved a week later that they can be given another set of blood. They would need to consent to that new treatment. So multiple treatments is really looking at where kind of that one episode of care has multiple pieces to it that the patient's consenting to. Another type of consent that really is not recommended is a blanket consent. This is when someone is agreeing to anything that might be needed at any time for their care. So it's any routine procedures that's needed. Ethically, this becomes problematic because consent needs to be contextual based on the diagnosis, the patient, and the circumstances at the time. So blanket consent doesn't really meet those components, and it's not something that we would be looking at in therapy. The difference between notifications and consent. A notification is when we give information to our patient about our procedures. So it's that intake paperwork where you're explaining your billing, your copay, maybe it's your late cancellation or not showing up for an appointment policy. You're just telling them these are our rules. This is how we manage things in our clinic. Consent is different. When the patient signs consent, that means that they are saying that they have been given the information that they need to make that decision about their care. So notifications are just, this is how we do things. It's a little more administrative versus related to the interventions and treatments that they're receiving. Some patients may choose not to follow the suggestions that we're making for them, that they have autonomy, they have the right to their own decisions. We have veracity, we have to tell the truth, and we need to be just. We need to, take the time to do that with every patient. But patients may refuse treatments for many different reasons. They may decline a specific treatment. They may decline seeing us Completely. Maybe in acute care, you go in to see the patient and they don't want to be seen right now. Maybe in outpatient, a patient is declining rolling up their pant legs so that you can massage a particular muscle or trigger point out. You don't know why, so you do have an obligation there to not just go, okay, fine, we're not doing that. Sorry, you're out the benefits of it. That ethically we do need to pause and think about this. Is there potentially a reason? Is it time? Is it expense? Is it how they're feeling they're not comfortable? Is it cultural? Do they not understand? Are they concerned or afraid? There are so many different reasons why someone may decline treatment, and we need to take the time to understand why. And I can't emphasize it enough, respect the patient's decision. If we are participating in true shared decision making with our patient, where we are clarifying their understanding of the situation, we're clarifying what we want to do for them, why we want to do it, all of those things related to informed consent. We find out from them, what do they want? What are their goals? What are their goals for maybe just this session, this moment in time? Are we clarifying and prioritizing what's reasonable? What do they want to work on first? And we explore their reason for refusal. That you might want to consider with your patients actually asking the question versus just saying, okay, good, we're not going to do that. Well, what leads you to that decision? Don't presume to know what they're thinking or why. Just ask, and ask them in a respectful environment that's comfortable, not in front of the whole clinic. Find some privacy and make it appropriate. Maybe you're not the best person to ask if you feel that there's some reason that the patient isn't going to be open with you. And then maybe you do have the opportunity to negotiate. Maybe it's a different clinician for them to work with, a different time of day if it's an appointment issue, maybe a different way to accomplish the same goal of the intervention. So participate in that shared decision making with your patients. Refusal of treatment is different than resisting treatment. So refusal is where they're actually declining some or all of the interventions. Resisting treatment is where the patient lacks decision-making capacity. So when someone refuses, we deem that they have the mental capacity to understand and they're deciding for them what they want to do. Resisting treatment is where a determination has been made, usually in therapy, it's by someone other than ourselves, that the patient does not have the ability to make the right decisions for themselves, or make decisions, I shouldn't say right, make decisions for themselves, so there's an authorized surrogate that's making those decisions. What we need to consider in those circumstances is that it may be approved, here's a perfect example, for that patient to get up and, the physician ordered ambulation. It's approved for that patient to get up and out of bed. It's authorized by their healthcare surrogate. And you go in and that patient is just refusing. They are not getting up. They are confused. They are in pain. They are just not going to do it. That doesn't mean that you muscle that patient up and drag them across the floor so you can document that you ambulated with them. Would that be ethical? Maybe what you need to consider is there another way to accomplish the intent given the patient's circumstances? Do they have a moment of lucidity where you can actually have a conversation with them? Or if not, do you have to actually get up and ambulate? Could you march in place? Could you get them to the bathroom? Maybe is there a desire that they do have? Get into their wants, their needs from whatever perspective they're coming from, that you can incorporate what your goal and intent is, put them first, try, step out of yourself and say, I just need to get these patients done. Or, oh, they just refused. So maybe try to get to the root cause and see if there are other possible alternatives that you can consider from your proposed treatment that's still within the scope for that particular patient. Think of that patient who is confused and pulling out their tubes, and that may be necessary for those in nursing to be in place with the patient. But in therapy, if it's an intervention or an activity, we may have more options of other ways to accomplish it. Let's take a look at a case study related to informed consent. Sam is a PT who has just received orders to begin ambulation with a 75-year-old woman who is status post a right hip ORIF. He goes to her hospital room to evaluate her and begin ambulation. She says that she does not want therapy today because she is in too much pain. Sam explains to her that the doctor has left orders for her to begin walking. The patient refuses. Sam leaves and returns the next day to try again. Again, she declines the treatment and he leaves. Under the guidelines of informed consent, were the therapist's actions adequate? What I want you to consider when looking at the therapist's actions are, in order for a patient's consent to be valid, they have to have all the information that they need to make the decision. That the therapist has to propose alternatives, that they have to go over risks and benefits. Was all that accomplished? No. This clinician didn't go back in and explain the risks and benefits. They didn't explore why the patient didn't want to get up. They didn't give them a different option to getting up. So ethically, this patient was not informed enough. Moving on to relationships in the clinical environment, we need to consider there are many different types of relationships that we develop in our clinical practice. We are people, right? We develop connections. We are caring people in therapy, so we're more likely to develop even more connections. But we are obligated to put our patients first. Our fiduciary commitment is to our client's best interest. So we need to have boundaries so that it's a safe therapeutic environment and professional relationships. Sometimes what happens in therapy is patients can accidentally blur the line a little bit. That some patients may interpret our desire for them to improve and our investment in their rehab and achieving their goals and getting their function back and contributing to their happiness in life, that they may perceive our investment in those successes as something more personal than the professional relationship. So the patient expects that we are going to be supportive of them, that they can trust what we say and how we care for them. And because of that, they sometimes think it means more. There's that transference, that sense of a deeper connection, which can sometimes blur the lines potentially a little bit in our interactions. So we need to have these very specific boundaries with our patients. We want people to like us, right? It's nice when you're liked. It's nice when you get along. But we can't overstep that professional line. We can't put ourselves in a situation where we've developed more of an emotional connection with a patient or their family that then compromises our ability to think as a professional and uphold all these other ethical standards. Consider this. Let's say you are working in pediatrics. So you single dad or single mom and you of the child, and you get talking to them more, you get to know them, you appreciate everything they've gone through, how they're working with their child. Maybe there's nothing physical happening. You have not overstepped that physical line, but you're emotionally connected. You're going to the school plays. You are going to the sporting activities that they may be participating. Maybe you're stopping by for dinner at the family's house. You have an emotional bond and a connection there that could be perceived as overstepping the line, because now are you looking at that patient of yours, that client, that child as a patient and you're a professional? Or are you looking at them as the child of someone you have an emotional, potentially romantic connection to? And how can you do that? It potentially is compromising that personal interest, may be displacing your primary professional responsibility in your decision making and welfare in the clinic for that patient. So we need to be cautious of these boundaries. There are clearly legal aspects related to relationships in most states, that sexual behavior, sexual potentially harassment environments are not legal. That is inappropriate, not tolerated. That is very clear that there is no place for that sexual type of relationship. But when there isn't that physical piece, maybe as a clinician, it's a little harder to see if you're potentially overstepping that ethical line. So we need to consider really restricting contact with our patients to appropriate times and appropriate locations to really keep it in that professional realm, and then doing the same for every patient. Because even if you feel, nope, I can still think of them as my patient, I can still make the right decision in the clinic. Are you going to the school play of every patient? Are you grabbing a cup of coffee with the mom or dad as a friend, or more than that, of every patient? If you're not, then is it maybe impacting your decision and you don't know? Why create that potential conflict? There are other types of problematic relationships that I want you to consider, not only with patients, but also with vendors coming in, other companies or physicians' offices. You want to consider not having inappropriate relationships with them, where there could be the perception that your decision making is not based on the best interest of the patient. It's because of some kind of perk or benefit that you may be getting from this other relationship. And this is where we get into gift giving and favoritism. Conflicts of interest can develop without our intent. And what happens is that crossing that line with a conflict of interest, even if we didn't mean to, even if it wasn't our intent, even if we don't realize, it just can't happen. That we need to really be alert to those situations going into everything, where you might inadvertently be motivated by something other than your patient's best interest. So we have two types of conflicts of interest. We have our apparent conflict of interest. And apparent conflict of interest is going to occur in that situation where any reasonable person who stepped back and watched your situation like an episode of a TV show would think that the professional judgment is compromised. So those are more apparent, kind of blatant, obvious kind of things. Potential conflicts of interest are those situations where, you have things separated right now. It's pretty clear there is no concern that judgment is compromised, but it could lead to something in the future. That there's the possibility that your expectations may change or your interactions may change just because of this relationship that has developed. And we're looking now more at relationships with, let's say, vendors, physicians, things of that nature. Gifts are what we're talking about, right? This is what it's coming down to. It's coming down to that gift giving. But what is a gift? It means so many different things. A lot of times when we think of gift, we're just thinking of something, tangible, something we're given. It's not necessarily that. We'll talk about the different types of gifts, but a gift could be some kind of perk or something you get that you didn't have to pay for, that you didn't have to put money out for. So why are gifts accepted? It's natural in society, right? Patients want to show gratitude, and they may do that through some type of simple, innocuous kind of gift. Sometimes it is more intentional, that it is intended to create something positive for one of the parties, that it's trying to get, um, some perk out of it. Other times it's economic savings for the institution. Other times it's just tradition, right? Some of you may be thinking right now, what would the holidays be like if we didn't have all those goodies? I'd be a lot thinner. Um, but, how would my patients feel in certain cultures if I don't accept that food they're bringing in for me? That would be an insult. That would impact our relationship. So there are lots of reasons that it might be seemingly appropriate to accept different types of gifts under some circumstances. But things being habit and kind of being just the culture of what's done really are not a reason to potentially risk putting patients' interests at risk and putting your benefit over the patient's. When we look at ethical guidelines for accepting gifts, there are some that we can utilize to help us make the best decisions. We know it is not okay if let's say, a vendor for a particular piece of equipment says, you know what, we are going to send your whole department to the Bahamas on a cruise, and then, if you guys are going to maybe in the next 6 months buy a big piece of equipment, we want you to buy it from us. Or they don't even say that, they just send you on this beautiful cruise for no reason. And guess what? The next time you have to order equipment and you have their brochure, you look at it and you're like, oh, Bahamas, yeah, let's get theirs. Not ethical. Now, if they said, you know what, we're going to put you up in a hotel in Colorado in the winter and it's beautiful there, you see the snow, I'm from Florida, so that sounds like fun, get all cozied up, at an educational conference. You're going to learn, this educational information that'll be beneficial for your patients, and then there is no intent of it being anything more than that. It just happens to be someplace nice. Maybe that's okay, right? Because that is giving you information to help the patients. That's not expecting you to do something that may or may not be in the best interest of your patient, the best choice for them, just because this company did something nice for you. And that's really where the distinction lies, that if accepting that gift would make you pick this over that for your patient, when that is better, but that didn't give you anything, this did, then that's where the ethical dilemma and the ethical overstepping is going to come in. When we look at accepting gifts, the key here is that if the primary purpose is enhancement of patient care and medical knowledge, then we are okay with accepting, generally speaking, those gifts. That the intent is not to get something. So they're sponsoring continuation education class, they're serving lunch. They are discussing a particular topic and they bring in, bagels and cookies. What's not okay is if they say, let's say a company is loaning you a particular piece of equipment. So they're saying, we're going to let you guys keep this, I'm trying not to use brand names, unweighted, supported gait training device that's crazy expensive and your facility could never afford. We're going to let you guys use it for 6 months and we're going to give you training on it, and then you can try it out with your patients so that you see who it works for and who it doesn't, and that's it. That's the end of the commitment. Good for the facility, they didn't have to pay for it. Good for you guys, you got the training and education. And if you tell your patients, you know what, I think rather than just ambulating in the parallel bars with a 4-person assist after you've had your stroke, that using this piece of equipment will let us better able manage your tone and get some gait training going, and the company happens to be letting us use it for free, does that sound okay for you? Informed consent? Good, good, let's go. What's not okay is if the company then says to you, if you can prove to us that at least 50% of your patients use this and it improved their outcomes, then we're going to give you guys a discount when your facility purchases it. Now you may make your decision for the wrong reason, intentionally or unintentionally. So that's really the key here, that you still have to keep the best interest of the patient in the forefront of things. We give gifts. We need to think about that there is an ethical and a legal consideration with it. If you have a patient who cannot do their home exercise program with the TheraBand because they cannot afford that piece of TheraBand, it's okay to give them that. It's not very expensive. It's under about $10. So that's okay to do that. But you can't do those things all the time, and you have to do it equitably for every patient. Just like gifts, it's okay for us to take, right? Those pens, those stress balls, all those different little things. Those aren't a big deal, right? Everybody gets those. That's not going to change your decision making. But when we give things to our patients, if we can prove that they're needy. But we can't put out there that every one of our patients in our advertising is going to get free TheraBand, because now they may come to you for that. And you're inducing a referral. So that's the key, that you also don't want to be soliciting or inducing referrals, because then you're giving something to get something back. And that's where the ethical line becomes blurred. You have to really be careful with waiving your coinsurance or copayment for Medicare patients or Medicaid beneficiaries. And this is really important to note, that there is a specific fraud alert that's out there. There are anti-kickback statutes from the Office of the Inspector General for the Department of Health and Human Services that if you waive the copay or coinsurance for your Medicare patients, that's fraud, potentially. Because what's happening here is a couple of different things. One is, if you waive that copay, that patient may choose to come to, let's say you diminish it, you don't waive it. Let's say you give them a discount. Their copay is supposed to be 10, they only pay 5. Well, you know what? They may come back to you again next time when it's not their knee, it's their hip, or now it's their back, because, hey, you give me a discount. So now you just got something out of that. That's not ethical. Also consider that it's fraud in the respect that there is a contract between, even if it's a third-party insurance, and the patient, that their premiums are going to be based on a negotiation, that maybe you have a higher copay because you have a lower premium. So if you waive this copay or reduce this copay for the patient, but the insurance is still giving them the lower premium because they think the patient's doing their part here, you kind of came in and circumvented that. You just interfered in that contractual obligation in that negotiation. So that could potentially be fraud. So you need to be wary of these things and be very aware of it. When we look at relationships between ourselves and physical therapy and other healthcare providers, we need to get referrals for our clinic, but we can't do that through means that are potentially unethical. So you can have a medical director at your facility. That's fair, but you have to pay him fair market value, that they actively have to be involved in the clinical care. You can't just give someone that title of medical director and be like, oh, by the way, if you happen to refer all your patients to us, good. No, that's unethical. If they're the medical director, they're actually involved, they're getting paid fair market value, great, that's okay. But any remuneration for any purpose of hoping to get referrals or build your business like that or services, that is unethical. If you're renting office space out, maybe you're renting office space out to, I don't know, a massage therapist. And you tell them, well, for every 10 patients of yours that end up looping back through the physician for physical therapy, I'm going to give you a $50 discount that month on your rent. That's unethical. You can't do those things. And that's common sense, or it should be. When we consider confidentiality for our patients, we are looking at maintaining our obligation of HIPAA laws and regulations and privacy rules, that we're not giving away any protected information that belongs to our patients. We're going to make sure that it's only given to practitioners that need to be involved in their practice, that we're not disclosing anything to any third-party individuals. Let's look at a conflict of interest case study here. Debbie Jones is a PT. She works in acute care and is meeting with a vendor whose company is introducing a new brace. He offers her 3 free braces to try out on patients and tells her that if she continues to order more braces, she'll qualify to receive compensation from the company by becoming a member of their national clinical assessment panel. Does this potentially present a conflict of interest? Consider that. In her professional judgment, Debbie needs to pick interventions that are right for every patient based on their circumstances. That we do have an obligation to manage at the facility. She has to be aware of costs and expenditures and maintaining costs for the facility. But we do have to consider conflict of interest. Are we making our decisions for the right reason if there is an intended perk? So in this situation, does Debbie's actions represent a conflict of interest? Our answer would be yes, because she is getting something out of it. She is getting a return on it. So that is potentially a conflict of interest. Relationships with referral sources. Larry Jones owns a private practice. Business has been poor. He decides to sublease half of his space to an orthopedic surgeon. His current lease is $20 a square foot, and the doctor's going to pay $15. That's what he's offering. And they compromise at $17 a square foot. And Larry tells the doctor that if he's the top referral source, that he'll make him medical director and pay him $500 additionally each month. In this situation, it's okay to have a physician we set as a medical director, but we cannot offer anything in hopes of referral. That goodwill gifts are okay, so those small little pens, pencils, things like that, or if we're doing things for an educational reason, but anything of monetary value we can't give in the hope of generating referrals. So in this case, is this ethical? No, for a couple of reasons. One, it's not fair market value in the first place if the original rent's 20 and they're compromising at 17. The other concern there is that there is that referral source coming in, and he's compensating the physician on top of that for making those referrals. So lots of concerns there. Let's look at our last quiz questions. Number 7, which of the following is not a requirement of informed consent? Number 7 is C. 7 is C. Number 8, which type of conflict of interest is considered unethical and should be avoided? Number 8 is C. 8 is C. Number 9, which of the following actions by a physical therapist is unethical? Number 9 is C. 9 is C. Number 10, which of the following scenarios is unethical? Number 10 is C. Tennessee. That concludes our ethics portion of this course, and we will finish with a quote from Albert Schweitzer, who is a theologian, philosopher, musician, and I picked him because he's also a Nobel Prize-winning physician. He said, "The first step in the evolution of ethics is a sense of solidarity with other human beings." And I think in our profession of physical therapy, we definitely have that solidarity in maintaining and upholding high regard for ethics for our patients and delivering quality of care. This is going to include discussion on the different laws and rules that govern practice in the state. You should note that it is your legal obligation, if you're a licensed practicing physical therapist or assistant in the state of Tennessee, that you have to follow the laws and rules for practice. If you're ever called before the board, they are expecting that you know what you were supposed to be doing out there in the clinic, not only in terms of techniques, but in terms of jurisprudence. It's unfortunate to hear that one of the common excuses that they hear from clinicians when they're called before the board is they didn't know they were breaking the law, and that is just not an acceptable excuse. So it's important that not just when you're required to take this course for your licensure renewal, but also at other times during your years, you should make a point to visit the websites that I'm going to provide you so that you can stay current on the laws of practice and the rules governing physical therapy in the state of Tennessee. If you're a supervisor, consider utilizing this as part of your meetings and follow up with your clinicians so that nothing falls through the cracks, so that you're always adhering to the highest standard and following all of the specific laws. When you look at the course notes that you either printed or saved electronically, on the last page of the packet, I included sheets with several different links, and it'll include those for these different documents that we are going to discuss. The documents that govern the practice of physical therapy in Tennessee, the first one is called the Practice Act. And that is Title 63, Chapter 13, specifically Parts 1 and 3 refer to physical therapy. The next one are the Rules of Practice, and that is specifically Chapter 1150-1. And then we have policy statements that are put out by the Board of Physical Therapy Practice. You're obligated to follow everything delineated in all three of these documents to ensure that you're following lawful practice. Let's take a moment to explain the difference between all of these documents because it can get confusing. First, the Practice Act. This is a legal document that is developed through the legislative process in Tennessee. It goes through the typical process that you learned way back in elementary school about how a law is enacted, and it is referred to as the Tennessee Code Annotated. Along with that, we have the rules of practice. So these are going to be adopted by a specific board of physical therapy practice that further add additional rules and clarification to that Practice Act that was developed by the state. Essentially, the Practice Act that's developed by the state, they're going to have similar things for every discipline in healthcare. They're going to define what the profession is, so in our case, physical therapy, who's allowed to practice it, what actions are prohibited. In addition to that, then when we look specifically at our practice, we have many considerations relative to delivering care for the patients. So that's where the rules of practice then become much more specific related to physical therapy. And then we additionally have our policy statements from the Board of Physical Therapy that will further clarify both of these documents. They do not contradict each other. Each one is meant just to give more information to help govern practice. You should note that both of these documents, the Practice Act, as well as the Rules of Practice, have the full force of the law when they look at regulating the profession and potential violations. provisions. Specifically, the statutes, which are referred to as the Practice Act, are referenced as in the Tennessee Code as Title 63, Chapter 13. And then parts 1 and 3 of that relate to physical therapy. What on earth does all that mean, right? So you go into this big document. Think of it this way. The code covers everything related to all aspects legally of the state functioning. So that includes everything in the code. They have to have titles that cover agriculture, how holidays are determined, how are the waterways run, taxes, crime, everything. So for each aspect, healthcare, there is a title that governs that. Once you get into the title, then there are many different pieces to consider. So once we get into the title specifically for the healing arts is medicine, there are many different types of clinicians practicing in the state. We have everything from dietitians to pharmacists to physicians to physical and occupational therapists. So once you get under those healing arts, those are our chapters. That's where you'll see all the different medical professionals listed. Once you get deeper into the document and you go specifically to the physical therapy section, it's broken up into parts. And part 1 of the laws for physical therapy are going to look at definitions and authorized practice. And then part 3 are going to discuss things like supervision, how do you obtain a license, what are disciplinary penalties. So it does follow a very specific flow, even though it sounds very confusing. Let's take a look at how you would actually find this on the website. Doesn't this feel kind of like your first time documenting when you were learning it back in school? What information do I need to include? The name of the exercise, the sets, the reps, the patient position. Well, when we look at how we name the statutes or how we refer to them to make sure you're abiding by each component, there is a specific process to the naming. So we said that the entire big document for the entire state is called the code. Once you get into the code, these are the statutes. Each one is a law. Statute's basically a law. How do we get down to the laws for physical therapy? When you open the website up, as we said, you're going to navigate down to Title 63. Those are our professions of the healing arts. And under there, you'll see many different disciplines. So we have psychology, veterinary, and then you'll get down to 13, occupational and physical therapy, which are grouped together as Chapter 13 now. Once you get into the occupational and physical therapy practice part, then we get into those parts that we discussed. So when we're writing this out, we'll go 63 for the title, dot 13 for our chapter, physical and occupational therapy, and then dot 1 will let us know we're in part 1. And from there, you're going to delineate out specifically which line and paragraph and item are you looking at in that specific document. When we get down to looking at that last segment where we are looking at the outline format, which specific outline level are we on? We're going to look here at this example. 03 is going to be the section, so that'll let us know that we are in a particular section. And then 16A will let us know that we're on level 16 of the outline, item A, and that's where you would read the specific information. So we are in part 1, section 3 of part 1, and then level 16A. And finally, now we can actually read the statute that we want to analyze. I agree, it sounds confusing, but if you need to find something and you go back and you follow what I listed out here, it will make it easier to locate. Let's look at a couple of examples. When we go into that part 1, and we know that we are in part 1 because it has that 1 here in that third place. So we're in part 1 here, and then different sections of that. So section 3, item number 11 is related to supervision. Items 12 and 13 are looking at the PT and PTA roles. Item 15 looks at assistive personnel and gives us a definition of it. And then we can go through all different areas here to look at that. So this just gives you a little general idea. If you're looking for a specific piece of information, which part of the statutes you can go back to. When you get into part 3 of the statutes, and we know we're in part 3 because we have in our segment here, we have 3 as the first digit, and then the next part, 02, lets us know that we are in item number 2 of part 3, and it speaks specifically about referrals and ethics. We'll see further delineation here on supervision. I listed that item out for you, and then how you can quickly find information on denials, confidentiality. So this is a little cheat sheet for you if you want to see where to find specific information in the statutes, which are the actual laws. So our statutes are our laws that govern physical therapy practice that went through the legislator. The rules are those pieces of information and that have been analyzed and adopted by the Board of Physical Therapy Practice. So it's going to be very specific to physical therapy practice. And those are in another different document. And the rules of PT practice are under chapter 1150-1. So those will be when we refer to rules. Now we're looking at a different book in that library. We're under the chapter 1150-1 to get into the physical therapy rules of practice. There are different sections to that, for that number from 1 to 22, and it goes through outline format. And in all of that, they are going to discuss very specifically everything from what's included in the scope of practice, how do you obtain and maintain your license, continuing competence, delineating out very specifically the different types of disciplinary actions and the consequences, consumer rights. So the rules are going to get more deeply into things that relate to your day-to-day practice of physical therapy that may already have been covered by the state in the statutes, or they may be things in addition that are specific to physical therapy. When you look at navigating this document, it again has a very specific pattern that it goes through to find the different rules of practice. So let's say you're looking for the rule related to the scope of practice of the physical therapist and when you can conduct an initial evaluation. You would go to 1150, which is the Board of Physical and Occupational Therapy Practice. From there, you're going to go to -01. So 01 lets us know that this part of that great document, we've gone to part 01, which is the Physical Therapy Practice Act specifically. And then once we open that large document, it's about, I think, 45 pages or 50 pages in total. Where in that would we find this information we were looking for on PT referrals? We say if we go to section 2 and then item 1A in the outline, it should take us to that information. So if we look here at the screenshot of the actual printed version, we see we have 15-01-.02. So we're in the Board of PT Practice, PT Practice Act. We are in outline item 2 here, and we're going to come down to 1 and then A. And in there, all of these following items are going to list out in outline format everything related to scope of practice. I know it sounds crazy to spend so much time going over how to find this information, but it really is important that you're able to navigate these documents so that if a question ever does come up, if you're in any of those ethical situations that we discussed earlier and you're trying to figure out what am I legally obligated to do, you need to know where to look and how to tease through, and then also how to refer to it appropriately if you are speaking with others, or you are going before the board, so that you know how to reference it. This board that I've been mentioning of physical therapy practice, there are specific members who are located on this board. It is through appointment by the governor that individuals applying are appointed. It's a 5-member group, and each individual is appointed for a term of 3 years. It will specifically include 3 physical therapists and 1 physical therapist assistant. Those individuals do need to have at least 5 years of experience each in order to sit on the board. They have to have enough practice experience in order to make judgments and rulings and assess the practice of others. There's also going to be a community member who sits on the board. And this is important because there needs to be representation from all the different stakeholders relative to physical therapy practice. Specifically, the individual who is the community member, they cannot have any affiliation with physical therapy. So they cannot have any professional connection or personal association with the field. So it's not a retired clinician. It's not someone who is involved in some other aspect of the healthcare industry. This is truly someone who is just a member of the community that sits on the board. It's also to note when we look at diversity of this board, because they need to consider their decisions from multiple perspectives and represent all the different stakeholders, is that somewhere in this mix of 5 members, at least 1 individual has to be over the age of 60, and at least 1 individual has to be of a racial minority, and then the gender balance has to be representative of the state's population. So that's a lot for them to figure out when appointing board members, but it's comforting to know that the individuals who are governing the practice are representing multiple different perspectives in their decision making. Policy statements that the board develops are instances where they're looking at the statutes, they're looking at the rules of practice that have been developed over the years by the previous boards and they've participated in revision of. And they say that, well, there are certain instances where, everything is just not clear. People still are confused. Clinicians still don't understand about dry needling. Even though we explain it, it's in legalese when you look at these documents. Maybe we need a little bit more of a layman's explanation referencing the legal phrasing, but to communicate the information. Or maybe there are specific things that aren't a line item in scope of practice, like yes, therapeutic exercise can be performed. Functional training is appropriate. Well, where do finger sticks and dry needling fit in there? It may or may not specifically be listed out, so they may create a policy statement that says, oh, well, that really fits under this part of the code or statutes. Let me explain it further. So that's where the policy statements are. And this is something that you need to follow because, again, all 3 documents come together and you're legally obligated to follow everything that's delineated in all of them. So there are kind of amendments almost that are adopted by the Board of Practice to clarify the laws and the rules. When you're applying these different laws and rules to practice, we're going to specifically discuss it from more of a perspective now of your day-to-day practice in a way that'll hopefully have it make sense. So we'll look at licensure, scope of practice, supervision, disclosures, and what I'll do is on every slide that references a specific statute, which is a law or rule from the Board of Physical Therapy Practice, or a policy, I'll note that. And on many of the slides about in this area, you'll see a square that has all those different numbers with periods and dashes that now hopefully make sense to you, and you can navigate back to if you want to see the specific information. Let's start out at the beginning with qualifications for licensure. And here's an example where I said all the different slides, I'll include this box here to let you know the specific laws and statutes that apply so you can go back and take a closer look at them. Qualifications for licensure, specifically in order to be eligible, you have to be at least 18 years old, good moral character. Specifically recognize you have to be a graduate of a CAPD accredited program and then pass the approved licensure examination. And this is going to be recognized by the state, that licensure examination. There are some instances where someone is exempt from having a license to practice in Tennessee and are still able to render services in physical therapy. Those examples we have here would be students who are supervised. They're not yet licensed. They need to be under the supervision of someone who is licensed, and we'll talk about that. Individuals who are in the armed services, public health, for the VA, they do not have to be licensed to practice physical therapy in the state. If someone is here from another country or somewhere else in the United States, a different state, and they come into Tennessee in order to attend a seminar that maybe has a hands-on component to it, where you're working with patients, they would be able to, as part of that educational seminar, still participate. And then individuals who are maybe traveling with athletic teams or the performing arts. Oftentimes, they have individuals on their medical support staff who are physical therapists or physical therapist assistants. So if that team or performing arts group travels to Tennessee and services are necessary, they could still be rendered as long as it's in conjunction with and under the supervision and employment of that entity. When we look at the paperwork that's involved in the licensure process, there are several different avenues that one can utilize in order to obtain their license in the state of Tennessee through examination, reciprocity, international education, as well as the physical therapy compact that we will look at.
First, we're going to discuss licensure by examination. And the examination for physical therapists and physical therapist assistants is the one endorsed by the Federation of State Board of Physical Therapy, FSBPT, or the successor examinations. In order to complete your licensure through the process of examination, you are going to apply to sit for the exam directly through FSBPT. And the clarification is here that you must complete all of those didactic requirements for your degree prior to submitting that application for licensure or for examination. So the didactic components of education have to be completed first. The hope is you're going to sit for that examination. The scores are going to be released through FSBPT. They will let you know that you passed the test, and then you're going to go through and meet the other requirements for the state of Tennessee in order to achieve your licensure. The passing level that has been established for the test is a score of 600 based on a rating scale of 200 to 800. If you are not successful in passing that test, when you sit for it on that first attempt, the new information from the state of Tennessee is that you're going to follow the procedures that are set forth by FSBPT or their successor in order to sit for that examination. Now, when you're looking for the information on how long do I have to wait, am I allowed to retest, how many times, in what time period, that's all going to be based, that eligibility for a retake as outlined by FSBPT or their successor organization. There's also a note that if within 12 months, and that's 12 months from when you're deemed eligible to sit for the examination, if you fail to pass the exam, you neglect to take it, or you refuse to take the exam, then the application for licensure is going to be denied and your file will be closed. You can reapply and restart the process at a later date, and then you'll have to follow all the criteria in order to accomplish that.
Individuals who are applying for licensure are analyzed critically related to their criminal history. There are some things that will require individuals to come before the Board of Physical Therapy Practice to be evaluated to determine if that license will actually be granted based on their criminal background. And this is considering anything that's happened in the past 5 years. So 5 years from the point of time when the individual submits that application for licensure from that date. There would be required appearance if anyone has a felony, multiple misdemeanors, class A or B misdemeanors that are occurring. A lot of this, to most of us, it doesn't really mean anything. We don't know what falls under that. So if you do have something in your past history, you'll need to go back into those other statutes or speak with someone who is well versed in it to determine if you fall under that required appearance. Individuals with some other serious misdemeanors, or if they only have one misdemeanor, based on the class of it, they may not need to apply. So they may not be required to come before the board. They would still need to disclose these items on their application, but the board may not automatically require them to come before. Ultimately, what will happen is the board in either any of these cases would request additional paperwork from the individual to make a determination on licensure. Reciprocity is another avenue that can be utilized to secure licensure to practice as a PT or a PT assistant in the state of Tennessee. Reciprocity is when you already have a license to practice in another U.S. jurisdiction. This is in lieu of taking the licensure examination. You probably had to take it at some point already to obtain that license in the other state. So what they do is they will have you file the necessary paperwork for licensure in Tennessee, and then they'll look back at your old test scores in order to decide if your license can be issued in the state. What happens is, based on when you sat for the licensure exam, it's changed over time. Going way back, there were several different parts to the licensure examination. There was a performance component to the examination. So it's definitely changed over time. The scores of what's passing, what's not, has been modified. So it looks back at a time period. I thought it's interesting to note that prior to 1976, if anyone is out there and still practicing since that time, they're just looking at that you met whatever criteria were in place at that time to be considered a passing exam score. Individuals who So between 1976 and 81 that were originally licensed in a different state, they had to be graduates of either a CAPTE accredited program or from the American Medical Association, because they may have graduated before CAPTE was accrediting. And then their minimum score is a converted score. There's a calculation that Tennessee will utilize to determine if the score that was obtained back in the 70s, 80s, or even early 90s is deemed acceptable for passing under current standards. And then those of you that have been licensed since July of 1995, that's the current standards that are utilized for the calculation of passing scores. So if your score was passing back then, it would be deemed passing now for you to apply for that reciprocity. And the examination that we are referring to is the one that is provided by the FSBPT. That is the exam that is recognized by the state of Tennessee for licensure eligibility.
There are some additional procedures that are detailed for that licensure through reciprocity. To be eligible for licensure by endorsement, which is reciprocity, that means you hold a license somewhere else and you're asking to become licensed in the state of Tennessee. At the time of application, the PT or PTA must hold a current valid license as a physical therapist or physical therapist assistant from a licensing authority in the United States. And if that criteria is not met, then you're going to follow the criteria and procedures that we'll go over for foreign educated. Right now, we're talking about individuals who do meet that criteria of holding a license from a licensing authority within the United States. So additionally, some criteria that need to be met, that you cannot apply for that endorsement if you are holding a temporary license. It must be a full license. There must also be proof of safe, competent practice. And the way that is defined is proof of active practice requires submission of written notarized statement that is sent directly to the board from the applicant's most recent employer or supervisor. And that will be to verify completion of a minimum 1,000 hours of safe and competent practice as a PT or PTA. And that did have to be completed in the 12 months immediately prior to your application. Additionally, there's an educational credential review process that requires submission of an original verified copy of your educational report. And that has to be reviewed in order to ensure equivalency of the education. And they will be utilizing the FSBPT coursework tool in order that corresponds to your year of graduation in order to look for that equivalency. Additionally, we're looking at passing the NPT examination, completing the ethics and jurisprudence requirement, also submitting that proof of the current licensure from a jurisdiction within the United States, and then the criminal background check. It's also important to note that it is the licensee's, or I should say applicant for licensure, responsibility to ensure accuracy of the FSBPT licensure verification report. Applicants for licensure by examination who are foreign educated need to submit several pieces of specific additional information. The first one is related to the educational credentialing review. Submission of an education credentials review directly to the board from an approved credentialing agency must be done, and that approved agency must have used the most recent edition of the FSBPT coursework tool in order to evaluate the applicant's educational to show that substantial equivalency that would meet the curriculum that would be evaluated in accordance with those FSBPT guidelines. Additionally, there is a requirement related to the TOEFL test that is going to be to establish English language proficiency. So the approved test is the TOEFL test, and there are minimum scores that are required in the writing, speaking, reading, and listening components. So I suggest that you do look specifically at the general rules for that. I have the details down here at the bottom of the referencing areas that you should look at for those specific scores, because there are some additional criteria about that those scores have to be achieved in one administration of the test. And then there is a note that depending on where you graduate from school for your training as a PT or a PTA, if your educational program is accredited by CAPTE, or if it's a non-CAPTE program, but it is a professional training school in several specific countries, that TOEFL requirement, there is an exception. The ethics and jurisprudence requirement, passage of the MPT exam, criminal background check, as well as the submission of verification of US citizenship or lawful presence. Those are the same that is what we're discussing for other applicants. That submission with the application of verification of US citizenship or lawful presence in the United States. I've had that on several slides because it does apply to all applicants for licensure. Specifically for foreign educated, one other component is that there is a clinical practice requirement. There has to be a board-approved, supervised clinical practice. Again, the criteria are going to vary based on previous licensure in the United States, where your training was, how long ago, and then the length of time and number of hours that you have to complete of that clinical practice are going to vary. So make sure that you do look at the specific rules to guide that to make sure you're meeting those criteria.
When they look at that equivalency of educational coursework, there is a policy statement from the board that goes a little bit more in detail to what is determined to be equivalent, because courses may be set up a little bit differently in the number of credits. So for English proficiency, they're looking at the TOEFL test, the TEAS tests that are standardized tests that are utilized for that component. And then looking at the credit hours, we all know for our degrees, you had to take so many credits. The curriculums were very specific and identified. And when we look at this relative to equivalency for a foreign educated clinician, they're looking at a minimum of 150 semester credit hours. And when they have the breakdown of that, there needs to be that general education component as well as the science and clinical science component. So looking at that science and clinical science component, that physical therapy specific coursework, they're making sure that that individual has neurology, orthopedic assessment coursework. There's coursework on diagnosis, interventions, clinical presentation related to cardiovascular, pulmonary, geriatrics, peds. Everything is covered in the coursework. They also want to make sure that the individual had at least 2 clinical affiliations, and they're requiring a minimum of 800 hours of clinical practice in total. And then to round out the education, if you're kind of checking this off, comparing to the education that you completed to see what else would need to be part of that degree, they're looking for the other professional coursework. And by professional coursework, they're referring to content related to research, culture, communication, ethics. So they're making sure that the education is equivalent to see if that individual would be eligible for licensure in the state of Tennessee. The last avenue that an individual can utilize in order to secure their licensure is something new, and this may be something that many individuals have not yet heard of if this is your first time taking the course since the compact has been initiated. But the Physical Therapy Compact, this is an agreement through multiple states, and the intent is that it's a contract between the different licensing bodies for physical therapy in several different states where they agree on the particular requirements for licensure. So they're saying that, and Tennessee has now joined this, that, well, if you're licensed in one of these other states, we kind of all are agreeing to the same state standards and expectations to grant you that license. So why do we need to go through all this paperwork again? Maybe we can slim down the process. So the intent is that the states that are part of the compact, when you are coming from a member state, going to licensure in another member state, rather than making the paperwork process convoluted, expensive, and longer to execute, where it could delay services to potential community members, it's making licensure more portable. So it requires an online application. Eligibility requirements are going to be more automatically and quickly verified. There is a fee that's required. And then you also need to meet the jurisprudence requirement in the state that you're applying for licensure in. Some other requirements in order to be eligible to secure your license through the compact agreement is that you do have to be licensed in your home state. That's part of the compact. You can't have any active disciplinary actions or financial encumbrances to your state within the past 2 years. You must also make sure that, as I mentioned, you complete the jurisprudence requirement in the state that you're transferring to, and that you're utilizing and practicing under the appropriate laws and rules of the license in whichever state you're practicing. And this is important for those of you to note that maybe live on the border of several different states, and maybe you're doing home care where you're crossing the border. The laws and rules of practice may be slightly different in those different states, so you have to make sure that you're following the appropriate guidelines. Once you secure this license, it is yours to go out and practice abiding by the laws and rules. However, within your 24 months, you're going to have a renewal cycle where you need to pay a fee and renew that license. So it involves that fee payment, an application, some paperwork, and then there's also a continuing competence requirement that we'll discuss the specific details of. At the time that your license comes up for renewal, you have a couple of different options. You can either go through the paperwork to renew your license, or if you're not going to actively be practicing, you have the option to convert your license to an inactive status, which is referred to as retired. Doesn't mean you're just going to go like chill on the beach or in the mountains and do nothing. It may, good for you, I'm jealous, but it might just mean that you're not going to be practicing in the state of Tennessee in the foreseeable future. So you're going to retire rather than just let your license lapse or cancel it. You just go to inactive and you file that paperwork. It makes it a little bit easier if you do want to reactivate your status again. Let's say you're moving and maybe you're going to come back. It requires a written request, some fees. You have to meet the requirements for renewal when you go to reactivate it, but it also is going to ask you to give a written report of what have you been doing related to your education and clinical practice in this time of absence of practice in the state of Tennessee. A lapsed license is a little bit different. A lapsed license is a situation where you've received that renewal for your license. You haven't said, here, initiate the paperwork to put me inactive or retired. You just didn't follow through. You didn't renew your license. What needs to happen at that point in time, it's important that immediately you cease practicing. This is really critical as you realize that you made that huge mistake. You have to stop practicing because practicing without a license is unlawful and potentially fraudulent if you're billing for those services. What happens as soon as you remember, you stop practicing, you contact the board. What you're going to complete is a reinstatement application. So you'll complete that reinstatement application. There'll be some additional fees penalties you have to pay, and hopefully you did this quickly and you get to maintain your license. The timing of this is very critical. If within 30 days, less than 30 days, you realize that you let your license lapse, you didn't send that renewal in, then what you'll do is you just give proof that you completed your continuing education courses, you pay those penalties and fees, and it is reinstated, no problem. If you end up lapsing for greater than 30 days, but less than 6 months, this is a concern. This is a long time, up to 6 months, to be practicing without a license because you haven't completed the paperwork. So this is a more serious offense. What happens is the board is going to give you an agreed upon citation. This is considered a disciplinary action that goes into your practitioner file. And as long as it's been less than 6 months, they're going to charge you a fee, which is going to be $250 per month for every month that you were practicing without your license. It's called a civil penalty. And then that fine will be paid, and then they'll reinstate your license. Assuming you've done that within 60 days of them notifying you of all of these requirements, you'll get your license back. If for some reason you don't follow through with all these requirements here, then at that point in time, or it's been greater than 6 months, you don't follow through, at that point in time, this is a serious disciplinary action because you were engaging in unlawful practice. So you're going to be referred for investigation and disciplinary action to the general counsel. This is a formal process, and there will be a reprimand. There will potentially be costs and fees and different types of disciplinary action. So you need to be aware of that. It also has repercussions related to your employment. If you have been practicing for all of this time without a license, billing for those services, your employer will have issues, potential fraud. So this is really serious that you mark your renewal date on your calendar, mark it early, and make sure you get that paperwork done. And as soon as you realize if you did miss it, take action quickly and stop practicing until you get it resolved. When we look at other considerations related to having that license, one aspect we need to be aware of is truth in advertising. For clinicians, it's important that we're honest with the public in every time you put yourself out there as saying, yes, I am a practicing physical therapist or physical therapist assistant in the state of Tennessee, whether it's verbally, internet, signs on your door, print materials, business cards, anything like that, disclosure to the public, you need to be very specific. And this truth in advertising policy exists because there's a concern that the public, they don't really know, they don't understand. Their expectation is if someone says, I'm a PT or I'm a PTA, that you are. So you need to represent that appropriately.
The general rules are specific in how we can refer to ourselves as clinicians. And what they are indicating is that anyone who has a valid, current, active license issued by the board can utilize the credentials of physical therapist, doctor of physical therapy, or physical therapist assistant. So those PT, DPT, or PTA credentials need to be utilized anytime you are advertising to the public. And they define advertising specifically as any informational communication in any format that you're utilizing to attract that public attention to the practice of physical therapy. So we want to make sure we're using those appropriate credentials because failure to do so is considered an omission of material fact. It could be considered misleading and deceptive practices. So we want to stick with that PT, DPT, and PTA.
What we'll do now is take a look at a couple of content questions. So number 11. Which of the following is not a law or rule that regulates the practice of physical therapy in Tennessee? And number 11 is A. 11 is A. Number 12, which of the following is true regarding authorized use of titles to denote physical therapy licensure in Tennessee? And number 12 is B. 12 is B. Continuing competence in physical therapy. In order to demonstrate this, they are looking at having clinicians remain current in interventions and techniques and ensure that there's ongoing knowledge and skills and abilities that are maintained and enhanced upon in order to practice in the state. And their goal is to really protect the consumer and ensure safe and effective practice. There are many different categories that fall under the continuing competence, the types of education that you can participate in, the methods of education or how you complete the training or education. The types are the different topics that you're able to cover. And the key here is that whatever you are participating in has to be beyond the entry-level educational experiences. So you can't just take a basic anatomy class again, or can't just cover information that was covered in your original physical therapist or physical therapist assistant educational training. Doesn't mean you can't have continuing competence courses or continuing education courses and interventions. They just can't be basic techniques. Same thing with examination, research, documentation, education, management, ethics, so many different things that you can look at, but it has to be looking beyond that entry-level practice. The specific requirements in Tennessee include during your 24-hour month cycle, because it's on a rolling basis for everyone. You all don't have the same date that you're renewing. It's 24-month cycle. So within that 24 months before your renewal month, you have to make sure that you complete, as it says in the actual rule, continuing competence credit is awarded for the clock hours spent in an activity as provided in paragraphs 5 and 6, except as provided in paragraph 4. All required hours may be met through Class 1 activities. PTs and PTAs must complete 30 hours of continuing education. What does that mean, right? Now you know how to navigate to those different locations to find the information, but let's translate this for you. What it means is that your continuing education requirement to renew your license is that you have to have 30 hours of continuing education. So those are contact hours and credit hours that are considered. So there's different terminology that's utilized that we'll go over, but the focus here is that you ensure that you complete a total of 30 hours, and that total of 30 hours of continuing education can be met a couple of different ways. Tennessee looks at two different classes of activities. There's Class 1 activities that, generally speaking, are face-to-face approved education type of experiences. And then Class 2 activities are kind of a little more extraneous. They're a little more independently focused and individual clinician generated, as opposed to something Class 1 that tends to be more of an improved type of course and a structured learning experience. So you have Class 1 and Class 2. You can definitely use all Class 1, and we'll go over specifically what Class 1 activities are to satisfy the licensure renewal continuing competence requirement. And if you're looking for what is the safe, definitive way to do this, it is through Class 1 activities that are pre-approved. Included is part of your Class 1 requirement. You must have 4 hours of the Ethics and Jurisprudence. So that's what you're completing right now, counts as a Class 1. So that's the type of coursework that you need, and we'll go over specific examples. And then everyone needs to have that jurisprudence, so that every renewal cycle, you have to have those 4 hours of jurisprudence. And this includes individuals who are completing their initial renewal cycle. So if you're going through that first initial renewal cycle, you have to complete the jurisprudence requirement, but they're not making you complete that other 30-hour requirement. So you don't need the full 30, you just need the 4 jurisprudence if this is your first renewal cycle. Because they're saying that your education to obtain your initial licensure is part of your competence and demonstrating it. Looking specifically at the jurisprudence requirement, this is the course you're taking now. We do get this course pre-approved, and that means that the Tennessee Physical Therapy Association has reviewed the course. They have looked at the credit hours and said it's awarding 4 hours, and they feel that it is covering the information that is listed in the rules that we have to discuss today. It's Class 1 activity, a structured learning experience, and you can utilize it for your licensure renewal. So we go through that work of having the course approved for you. Other types of courses that you can utilize to meet your Class 1 requirements. So there's many different ways. You could do Class 1, 20 hours you must have minimum, or you could just do all of them. And what this means in Class 1 is that they are courses, workshops, seminars that are approved continuing education courses. So the Board of Physical Therapy Practice says you have to have continuing competence proven. You have to have continuing education courses to get your license, but don't send us all your paperwork to see if we think the course is of good quality that we're going to accept it. What they say is the organizations that offer these courses will go through the approval process and make sure that the course is approved. So whenever you take a course, for example, with Innovative Educational Services, when you see that number that says Tennessee approved, that means that we went to the Tennessee Physical Therapy Association, they approved that course, so when you submit it for licensure, it will be accepted. Other courses that are automatically approved and accepted are courses that are offered through universities that are CAPD accredited programs or other university level courses. You're able to take a set number of coursework through that mechanism. If you have an advanced degree that's issued through the university, let's say you've gone back to school and you're able to submit that and have that count towards your Class 1 competence. Again, these are structured learning experiences.
There are specific organizations that are authorized to approve the courses, seminars, workshops, and symposium that you're attending in order to meet your continuing competence requirements. Those include the American Physical Therapy Associations or its academies and sections. It's important to note with that state chapters of the APTA are not considered approved providers. So if you take a course in a different state that's been approved by, for example, the Florida chapter of the APTA, that does not mean that same course is automatically approved for you to use to satisfy your continuing competence requirements in Tennessee. It does need to be approved by the APTA Tennessee chapter, or APTA and its academies, FSBPT, and then also courses that are completed through accredited PT or PTA educational programs.
Just to reiterate, I have the actual statement here where the Tennessee board is basically saying that it's up to the individual practitioner to determine if it's your responsibility to determine if a course you take is going to be applicable and appropriate beyond entry level, of the appropriate content, of the appropriate hours to meet licensure requirements. That's a huge burden. I think it's a lot easier to take a course that you know is approved through a continuing education provider, where the provider already went through that process for you. So then there's no questions. So in addition to those approved courses, another way you can meet Class 1 competence is if you're the presenter of a continuing education workshop or approved course. You're limited to 12 hours in that capacity. If you're the author of a peer review research, so if you actually are published and you retain a copy of your publication, that effort that you put in could be awarded continuing education hours under Class 1. If you do a presentation of a scientific poster from research that you completed, they're going to limit the hours, and definitely there's a disproportion between the effort it took for you to create that article and go through the peer review process and get published, and how many continuing education credit hours they'll award you. So it's about 10 hours that they'll award you for that. And we know it took you a lot more than that, but it can count. If you're adjunct teaching in a CAPD accredited PT or PT assistant program, you want to make sure that this is not part of your normal teaching. So if you're employed full-time as faculty and teaching courses is part of your normal load, then you can't use that for your own personal continuing education. It would be if you're an adjunct, let's say you're practicing in the clinic and then you adjunct instruct, that could count as Class 1. You can't take the same course and let's say you teach it every spring semester and say, okay, well in 2016 I taught it in the spring, and then 2017 I taught the same course again in the spring. That should count twice for me. It doesn't work that way. Any course you instruct for the renewal cycle of 24 months, you can only count it once, and they're going to cap your number of continuing education hours that you can achieve for that. And the specifics are delineated out in the rule. Other Class 1 activities are external or internal peer reviews. So if you have someone assess your actual clinical skills, they observe you, or you complete some type of formalized assessment through the APTA, that can count. You can only do that once during your renewal cycle. An internal review, that would be maybe a peer. Now they have to have it documented. So this is not just like, oh, well, my renewal's tomorrow. You've seen me practice, right? It's not like that. We're looking structured because the intent is continuing education. We're improving our practice. So they're, again, limiting, if you have a peer review you and have documentation, that 2 hours, maximum twice in your renewal cycle, you can do that. If you obtain your clinical specialist certifications through the American Board of Physical Therapy Specialties, cardiopulmonary, women's health, pediatrics, they might also accept, it's indicated in the rules, potentially McKenzie, NDT, Olga Grimsby, some other specialist certifications, and they'll restrict the number of hours. Right now that's limited to 26 hours that could be awarded for those certifications. If you attend a clinical residency program, then you are able to receive 5 hours of continuing education credit for each week of residency you participate in. Again, there's a disproportion between the effort you're putting in and the continuing education awarded, but remember that you're not just taking the courses to get the CEU hours, you're taking them to glean information to improve your clinical practice. So it's a extra perk, let's say, that they'll also let you double dip and use it for your licensure renewal. Those are all our Class 1 considerations and items that would meet that type of documentation. So those are real, live, interactive, all those experiences, structured, that I just explained. Class 2 competence is a little bit different. These are things that will be accepted. They restrict the hours to a maximum of 10. You could use no Class 2 if you want. if you feel once you hear them that you're like, oh, I don't know if I could really justify that, or that's not my type of experience, but they do allow them. Examples would be self-instruction from reading professional literature. So in that case, that if, at 1 hour, you're able to utilize kind of the honor system in this case of reading professional literature. If you participate in a group study session, maybe to discuss professional literature or a particular technique or skills, you have to have 2 or more clinicians. You're going to get 1 hour of continuing education credit awarded for every 8 hours that you participate in the study group. So there are some other restrictions on that. If you present a scientific poster, serving as a clinical instructor is another great opportunity to support the next generation of our profession, as well as you have the benefit of obtaining some continuing education hours for yourself. It's a 1:16 ratio. So for every 16 hours you supervise a student, then you will receive 1 continuing education hour that you can submit. Also, APTA service, if you're a delegate, you're on the board, a committee member, maybe you serve on a task force, you can use 1 continuing education hour to represent all of your effort that you've put forth in the capacity of serving the American Physical Therapy Association. Some unacceptable activities, whether they're class 1 or class 2, would be OSHA training, Tennessee OSHA, CPR, safety courses. Those are not beyond entry level. If you attend non-educational professional meetings, so let's say you're going to a business meeting of the association or a professional organization, those don't count. Same thing with policy and decision-making meetings. You can't go and visit, the live anatomy exhibits and say, yes, that was educational. Those things don't count. So they do have some specific restrictions because, again, the goal is to enhance and improve practice. When you look at the documentation that's required, you do have to maintain documentation. As I said, it's easy to go with those type 1 class 1, pre-approved courses. You have that certificate that you print, the course information is there, the number of hours awarded, the pre-approval, it's nice and clean and it's easy. If you participate in reviews, then you need to make sure you maintain documentation of that, who performed the review, transcripts for any educational credits that you received from a university. If you are published, you want to keep a copy of your published study, proof that it is a peer-reviewed journal. For self-instruction, if you're going with those study groups or that information, maybe you presented an in-service at your facility, those types of things you really want to keep good documentation on, what you did, the objectives of the program, your specific role, something to prove you were the presenter. Because what happens is if the state audits you to see how you met your hours of 30 to achieve continuing compliance, they are going to give you 30 days to submit all this documentation. So you have to have it ready beforehand. So you want to make sure that you are prepared and you're doing everything ethically and legally in the first place. If they do find that someone is non-compliant with the continuing education requirement, do you have a specific policy statement on how that is handled? It's interesting to note that if you are a physical therapist or an assistant that you have had continuous licensure in Tennessee since 1960 and you're at least 71 years old, it's possible, I did the math, you're exempt from all of this. But for the rest of us, we do need to meet those continuing competence requirements. What happens is if somehow they find out that you were not, let's say you were audited, and they say, okay, you need to submit us your documentation, you kind of have that 90-day grace period before there's any disciplinary action in order to prove your continuing competence. And submit your documentation. So what you need to do is make sure you have all your documentation together. If you are notified that you need to submit your proof of documentation, you will send that in. If you get it all cleared up within the 90 days, not a problem, you're all set. If they look at your case and it has been less than 8 continuing education hours that are completed. So let's say in your 90 days, you get it done, you have your 30 clean. If you had less than 8 continuing education hours completed within 30 days, you need to, of being notified, you need to pay a civil penalty of $100 for every CEU that you're lacking. You need to submit documentation that you made up those missing hours, and then they will allow you to continue with your licensure. If they find that you have less than 8 continuing education hours completed, so you're severely deficient and you have not been attentive to the laws and rules in terms of continuing compliance, they're going to give you 30 days to pay, again, that $100 per CEU credit that you're lacking, make up the missing hours, and in this case, they are going to suspend your license for at least 30 days. So you really want to make sure that you are on top of this continuing compliance. Some exceptions are those who are active duty military. They may not have been able to complete the licensure requirements because of deployment or other responsibilities, so they're not going to be charged any late penalties. If their license is expired for less than a year, they do not require any continuing education, and if it's greater than a year, they only need to meet half of the requirements for the continuing education. Let's take a look at a couple more applications of these concepts. Number 13, physical therapists and physical therapist assistants must complete blank hours of continuing education during the blank months preceding their renewal month. And number 13 is D. 13 is D.
14, which of the following is true regarding Tennessee physical therapy continuing competence? Fourteen is A. 14 is A.
So the scope of practice indicates that the physical therapist is going to evaluate individuals with physical and developmental impairments, as well as functional limitations. They're going to determine from this evaluation the prognosis for achievement of specific goals, determine the interventions that can be utilized with that individual to progress them towards the management of the specific condition that's being addressed on that evaluation. When we look at the various interventions that are utilized under the delivery of physical therapy services, the types of interventions that are going to be implemented include a variety of everything that we all learned in school, using manual techniques, so hands-on techniques to manipulate the tissues and alleviate pain, address any edema or swelling or range of motion restrictions, therapeutic exercise, modalities to increase range of motion, function, strength, balance, as well as anything else that goes into functional improvements for the patient. Prosthetics, orthotics, assistive equipment. Another component of physical therapy services delivered by the PT and the PTA include education and reduction of injury, as part of the scope of practice. There are a couple of specific instances of types of interventions where the Tennessee Board of Physical Therapy has indicated specific policy statements in order to help guide practice related to health screenings, dry needling, and finger sticks. So we will take a look at those. One other aspect to address that is mentioned specifically in the laws for the practice of physical therapy in Tennessee is related to thrust movements, so the manual manipulation of specific joints. It's very specific in the delivery of physical therapy services that the interventions and treatments that are utilized do not fall under the care that's to be rendered under the scope of practice of other disciplines, such as nursing, chiropractic, medicine, osteopath, and podiatry. So we can't infringe upon those disciplines. And one aspect where we need to be specific is that direct thrust movements cannot be utilized in the field of physical therapy practice. When looking specifically at multidisciplinary health screenings, these are the types of screenings that occur maybe at health fairs or community service type events. They're outside of situations where physical therapists and PTAs are typically practicing, such as hospitals, outpatient clinics, home care, school settings. So these are looking more at your health fair type events where health screenings may be completed, or other types of settings where health screenings would be conducted. What the policy statement discusses is that clinicians participating in those types of events, PTs and PTAs, they really have to be cautious to stay within the scope of practice of physical therapy. Anything that's performed outside of the scope of practice in those particular settings could be deemed as unsafe to the public. And if that is considered outside of the scope where safety is compromised for the public, then you could be under scrutiny, which could potentially lead to disciplinary action and potential malpractice litigation also. So you really want to be cautious if you're participating in health screenings that you stick with types of treatments or assessments or tests that are typically within the realm of physical therapy. So things to consider would be, is posture assessment in the scope of physical therapy? Blood pressure, things that are typically instructed in the educational programs are very clear to say they're within the scope of practice. Dry needling is something that has emerged and is falling under the scope of practice of physical therapists specifically. This technique, if you are not familiar with dry needling, it is the use of thin needles that are placed into a muscle trigger point. They may be superficial or they may go deeper down into that trigger point in order to alleviate pain and promote range of motion for the individual and movement and functional tasks. This specific technique can be utilized as a treatment intervention by physical therapists in the state of Tennessee, given some specific guidelines. Individuals have to receive in-person instruction in several different areas. So the physical therapist has to have 50 hours of content delivered in person on approved coursework that relates to things that are typically already covered in the PT school, musculoskeletal and neuromuscular assessment and anatomic knowledge, the anatomic basis of pain, mechanical pain, chronic pain, referred pain, understanding the differential diagnosis there, as well as understanding trigger points and universal precautions. In addition to that knowledge, the individual needs to also go for 24 hours of specific dry needling specific training. So that 24 hours of dry needling instruction is going to include not only direct practice and training in the hands-on technique of the needling. It also has to go over indications, contraindications, adverse effects, OSHA, documentation, the physical reaction that the patient may have, everything in order to appropriately perform dry needling on the patient, because the reality is most clinicians, unless they're newer coming out, have not received this instruction. So the state wants to be sure that clinicians are skilled in this new technique in order to practice it. The key here is that it can only be performed, assuming this person has the appropriate instruction, by a PT who received all of this education pre-licensure, so as part of their CAPD approved education. And the individual who does not have the training as part of their initial education and goes on to complete it post-licensure and post-initial degree, they need to have 1 year of clinical practice. Patients have to have a specific informed consent for dry needling, just like everything we've spoken of before. But with this, they want to make sure that the individual receives proof of informed consent in what is the treatment, the risks, the benefits, the side effects. So those of you performing that intervention, be sure that you also adhere to this portion of the rules. Finger stick techniques. So in this case, the board is considering when you're treating a patient who may use a glucometer, or maybe there needs to be Coumadin checks that are done to assess the clotting of their blood. The determination was made in the policy statement that the performance of those finger stick techniques are within the scope of practice for the PT as well as the PTA. The caveat is that they're performed and called for during the course of practice of physical therapy. So this is as part of your treatment. If you need that information or need to perform that assessment on the patient, then it is considered within the scope of practice under the Practice Act. When we look at how our patients arrive to us for therapy, so we can perform all of these interventions and skilled care that we've been discussing, we look at different access points in terms of referral to provide services. So we may be receiving patients through a direct referral route, or we may be seeing patients through direct access. So that is where they're coming to us without a specific referral, but there are opportunities for the physical therapist to deliver care.
When treating a patient through the referral process, those referrals for physical therapy services can be accepted from several different types of practitioners. They can be in written or oral format, and they can be from a licensed doctor of medicine, chiropractic, dentistry, podiatry, osteopathy, and also from a nurse practitioner or physician assistant. The rules do provide an opportunity for direct access, that treatment without a referral. A licensed physical therapist may treat a patient without that referral within the scope of practice of physical therapy when certain criteria are met. The first one is that the patient's physician must be notified by the physical therapist. Notified is defined in the rules as to give notice or inform the physician. The other criteria is that if the physical therapist determines, based on the clinical evidence, that no progress has been made with respect to the patient's condition within 30 days immediately following that initial visit, then the physical therapist should cease providing additional physical therapy services and refer that patient to a healthcare practitioner who does qualify as a referring physician or referring practitioner. If the patient is progressing, and then the physical therapist needs to note that they do not continue physical therapy services for the patient beyond 90 days without consulting with the patient's appropriate healthcare practitioner. And then at any point in time when treating the patient without that referral, a physical therapist must refer the patient to the appropriate healthcare practitioner if at any time the physical therapist has reasonable cause to believe that the symptoms or conditions that the individual is presenting with require services that are beyond the scope of practice of the physical therapist, if reasonable therapeutic progress is not being achieved for the patient, or if physical therapy treatment is contraindicated. The rules are a little bit different for patients that have previously diagnosed conditions. So if you're seeing a patient who was previously diagnosed by a licensed physician with a chronic condition, a neuromuscular condition, or a developmental condition, and the evaluation, treatment, and services that you're now providing are being provided for problems or symptoms that are associated with one or more of those conditions that the person was previously diagnosed with. In that case, those 30 and 90-day guidelines that we just discussed do not apply. Still, we need to remember that the patient's physician does need to be notified, and also that if at any time the care that's being provided is beyond the scope of practice, progress is not occurring, or treatment is contraindicated, then that patient needs to be referred to an appropriate practitioner.
The scope of practice of physical therapy shall be under a written or oral referral from the practitioners that we previously discussed, with a few exceptions. The first is that the initial patient evaluation may be conducted without the referral. And then also, a licensed physical therapist may provide physical assessments or instructions, which can include recommendations of exercise to an asymptomatic person. And that's again without a referral from a practitioner. In emergency circumstances, there's another opportunity for physical therapists who are licensed to provide services to individuals. So, including minor emergencies, a licensed physical therapist may provide assistance to a person, and this is to the best of the therapist's ability without a referral being necessary. The way that emergency medical care is defined, or these emergency situations, means they're bona fide medical emergencies that occur after the sudden onset of a medical condition that manifests itself by acute symptoms. And those symptoms can include pain. And they're symptoms that are of a sufficient severity where if the individual did not receive that care, that person would be placed in a position where their health is in serious jeopardy, or where serious impairment to their bodily functions can result from not receiving care. And then lastly, if serious dysfunction of any body organ or part could occur if those services were not provided. The additional component related to provision of care under these emergency circumstances is that immediately after providing the emergency assistance, the physical therapist must refer that person to the appropriate healthcare provider. Telemedicine and telehealth is expanding, and this is addressed in the general rules with some specific criteria that you need to be aware of. When we talk about telemedicine or telehealth, this is when the therapist and the patient are not at the same location. That patient is at a distant site, but we're still providing services as a PT or a PTA for diagnosis, consultation, or treatment. This can happen a couple of different ways. It's basically broken down into either a real time interaction, audio, video, some electronic platform where you're interacting live with the patient, or it can occur asynchronously. This is what we call store and forward telemedicine services, where patient data, images, videos, reports, they are sent securely through an electronic service, and the clinician, you're going to review that later and then loop back to the patient for your interventions and interactions with them. So there's two different ways that you might be using those telehealth services. Some additional details that you need to be aware of is, in any case, what is important is to establish that provider-patient relationship through mutual consent and mutual communication. So mutual consent means that the relationship is established in one of two ways. It could be expressly through written, clear consent that has been provided and stated from the patient, or it could be an implied type of consent where the patient has attended the visit, they scheduled it, so that is serving as their consent to participate. In addition to all of the other ethical and legal requirements related to consent. In terms of the communication piece, mutual communication, when we look at telehealth, this specifically is explained that just because data is sent electronically or through some medium of telecommunication, it doesn't mean that just because as a clinician you receive that patient's information that you have established that patient-provider relationship. There has to be some type of active engagement between the clinician and their patient in order for that relationship to be established. So that's what they mean by active communication and mutual communication. It could be a video interaction or a live audio interaction where there's some exchange happening, some actual engagement, and then the clinician is affirmatively participating. They are looking at the information provided by the patient. They're actually interacting with them. It's not just receiving data, that you're providing guidance, you're performing planning. So there's that active piece to this. And then with all of this care that you're providing through telehealth, this does need to be completed with the same scope and standard of practice expectations as in-person care related to ethics, documentation, professional responsibility, and the scope of services that you're rendering. As we look at transmitting patient information over electronic media, we need to be aware of patient identity and communication. Establishing patient identity is important. It needs to, at the initial contact, be verified at the start or prior to each session. And then when you first communicate with that patient through whatever source you're utilizing, software program or technology, you need to obtain an alternative way for you to contact them as well as them to contact you. It needs to have another backup option. We need to consider those emergency circumstances, make sure that the patient knows how to get in touch with you through another way if they become injured or something urgent and time sensitive is happening during their treatment time with you. We also want to make sure that when we're transmitting patient information, we are doing so in a secure format. And again, that informed consent is occurring. Other laws and regulations for compliance, the PT or the PTA that is practicing through telehealth or telemedicine services is going to demonstrate compliance by having that active license in the state of Tennessee, or they're going to be eligible to have those current compact privileges and you're in good standing with your license. Also, there is statement that the clinician needs to be authorized by law to practice in another jurisdiction where the patient is physically present or domiciled. And then again, criteria to make sure that you are remaining in compliance with all federal, state laws, board rules, regulations for practice. Electrophysiologic studies have different criteria for that need for a referral and how you're going to access your patient, because there are a couple of different situations where you might be performing these services. This is specific to the physical therapist. Motor and sensory nerve conduction, somatosensory evoked potentials are what we're talking about when we reference those electrophysiologic studies. There does need to be a referral in order to provide these services, with one exception, that the invasive electromyography, this can be performed in a university setting that has a research project that the clinician is participating in, and that research project does need to be approved by the educational institution's internal review board. And if that's the case, then that referral is not needed. As we look at the specific performance when we are performing the referral-based services for these types of studies, clinicians that are performing the diagnostic electromyography. So this is going to be the invasive needle study of multiple muscles for the diagnosis of those muscle and nerve disease conditions. It is required that submission to the board occurs with documentation of evidence of that clinician possessing ECS certification from the American Board of Physical Therapy Specialties to ensure that they have the skills and knowledge to execute those treatments appropriately. And then if the performance is related to just the surface electrophysiological studies, those would be motor and sensory conduction, somatosensory evoked potentials, and also kinesiologic studies, where they're the invasive needle studies, but it's of the muscle to determine the degree and character of the muscle during certain movements. In those cases, the clinician does need to submit to the board evidence of not the sufficient theoretical background as well as technical skills in order to appropriately and competently perform those specific studies.
The disclosures that you're going to provide your patients, in addition to the informed consent that we've discussed, you might need to include in your outset of paperwork with the patient, or any disclosures you have related to financial arrangements, anything that is related to your confidentiality with third-party involvement, because they're not allowed to have access to patient confidential information unless there's a reason for medical services or the patient consents. Any financial interest that you may have. Something else to note here is that a copy of each clinician's license has to be displayed, and it has to be displayed in an area where there is open view to the public. So you can't just have it back in the office somewhere hanging on the wall. It has to be out visible where the public does have access, because that is that part of that truth in advertising. They can see you're actually licensed. Let's take a look at a case study related to confidentiality. John Jones is a physical therapist, Sue Brown, therapy receptionist, and Mary Smith, who's the director of managed care contracting, are in a private physical therapy office discussing the fact that they are treating Biff Simpson, a star NFL quarterback. John says, "I can't believe that I'm actually treating Biff Simpson." Mary asks, "How bad do you think his injury is?" John replies, "I saw his MRI report. It looks like he's going to need surgery. Is this a breach of confidentiality?" Some points to consider when you're deciding the answer to that question is that we have to safeguard patient information against disclosure to any non-proprietary individuals. Only individuals that have the right to know information is based on need to provide medical services to the particular patient. And the type of information is only what's appropriate to render care. So given this situation that we described, was there a breach in confidentiality? And your answer should be yes, there was a breach. So there are several things here to consider, and it does get into HIPAA regulations also. That personally identifying information, John in his first statement put information out there that he should not have shared in that situation, that he gave the patient name. He identified them, related to football, so that could be identifying information. He shared diagnosis information, test results. That's not appropriate because the other two individuals listening didn't need access to all of that. Maybe the receptionist does need to know the patient's name so that they can do scheduling. But beyond that, the other individual, you're disclosing to a third party. Mary, who is involved in contract management services, has no need to have any of that information. So it's a breach of confidentiality on several different levels, which is easy to slip into, but as we have this renewed awareness of the confidentiality and everything legally and ethically that we're discussing, why the state has you take this course is to keep it in the front so that we can abide by the appropriate regulations. We'll take a look at a couple of more post-test questions. Number 15, Tennessee licensed physical therapists may treat patients under the referral of which healthcare professional? And number 15 is B. 15 is B.
Question number 16. Which of the following is not an exemption allowing a physical therapist to provide care without a referral? Sixteen is C. 16 is C.
Moving on to supervisory relationships, the laws and rules dedicate a lot of time to being very descriptive in the definitions of the different practitioners involved in physical therapy, as well as the specific supervisory relationships. When we look at who we need to consider supervision of, we initially have our physical therapist, and then we have our PT and PTA relationship that will be specifically delineated with the physical therapist assistant working under the supervision of the PT. And then lastly, we have all of these other practitioners as well as individuals that may be present in the clinic, from volunteers to students, aides, individuals with other credentials, maybe massage therapists, athletic trainers, and then home health aides. So the criteria for supervision and the definition of each of these practitioners needs to be understood to make the appropriate decisions in the clinic. We'll look at each one individually.
Supervision of the licensed physical therapist assistant who is practicing in Tennessee means that all of the services are being performed under the supervision of a physical therapist who is also licensed to practice within the state of Tennessee. Some additional information regarding this: we know that the physical therapist is going to perform that initial evaluation. They're going to develop the PT diagnosis, consider the prognosis, write up those goals and treatment plan, including with the goals, the frequency, the time period, all of that information. And then the physical therapist assistant is able to render that care in a variety of settings. In terms of how the physical therapist is required to supervise the PTA, the current general rules indicate that the physical therapist must be available to communicate with the PTA via phone or other means. They are leaving some flexibility there in terms of what those means are. What is important to note is that it's while the PTA is delivering services. So we need to be sure that that physical therapist is available for consultation, to discuss the patient's status, goal revisions, any of those things during that time that the PTA is delivering care. So be careful to consider weekends, holidays, evenings, different hours that clinicians may be working to ensure that this supervision requirement is met.
There's also specific information and timelines related to the physical actions that the PT has to take to remain active in the patient's care. So we know after the initial evaluation that PTA can begin treatment with the patient that they have been delegated. As time passes, at least every 30 days, the physical therapist has to perform and document a reevaluation, assessment, and plan modification. So every 30 days, they have to physically see that patient and then document. And then the PTA can continue with care after that point. Every 60 days, additionally, the PT has to inspect the actual act of therapy. And I can't emphasize that enough, that it doesn't just mean you go in because it's been 60 days to do your reevaluation with the patient and you treat the patient instead of the PTA treating the patient. The rule is very specific that they have to inspect the act of physical therapy services that are being rendered. And then when it comes to discharge, there actually has to be a discharge evaluation that's completed and a written summary on the patient. There's a position statement that was added to reinforce this even more about discharge. The position statement actually explains that it may be challenging or difficult. Sometimes the physical therapist doesn't know that the patient is going to be discharged, that it comes up quickly depending on the setting. But they said that PT records are not complete unless there is that final discharge evaluation and a written summary on every patient. They make a point of reiterating that in their policy. So definitely make sure that you have procedures in place so that you can be in compliance with this criteria and portion of the law. The accountability for this, it's not finger pointing. The PTA, you can't say, well, I tried to contact the PT and I told them we needed new goals and I had an appointment for them to come and watch my session and they didn't. And the PT can't say, well, that PTA is great. I know they're doing what they need to do. I don't need to check in on them. It doesn't work that way. That both parties, by law, are equally responsible and held accountable for these supervision provisions. So it works both ways. It's a partnership. Even though the PT is supervising the PTA and overseeing overall patient care, they have that obligation. As the PT assistant, it's still your responsibility to make sure you're in compliance with all of these timelines. There are multiple supervisory relationships that can be going on. PT assistants can also have roles in supervision. So we're going to look at, we have the Board of PT licensed practitioners, the PT and the PT assistant, and we just discussed the supervisory relationship between the PT and the PTA. Then we have this group of individuals who possess credentials that may be from other accrediting bodies or different organizations, athletic trainers, exercise physiologists, massage therapists. They have training and some other level of certification or licensure. And then finally, we have individuals who are only trained under the direction of the physical therapist. So aides, transporters, they're not specifically formally educated and trained clinicians. We need to look at the different supervisory relationships here. When we look at supervision of physical therapy aides, the laws are very specific that aides, techs, transporters, that these are individuals that they do not perform any actions that require the decision-making of a licensed PT or the problem-solving of a physical therapist assistant. So these individuals are receiving on-site direct supervision. The physical therapist or the physical therapist assistant is right there immediately, physically seeing everything that they're doing. They've been trained in the tasks that are delegated to them by the physical therapist, and the routine tasks that they're performing, there's no list, but what can everyone agree upon would be routine? You know, bringing a patient to the gym in the wheelchair. Maybe a patient who's ambulatory, walking them from the waiting room in. Can they apply a hot pack? I mean, consider that. That takes clinical judgment and problem solving, right? That patient's skin integrity has to be assessed, their tolerance, the positioning. That's skill. That is probably beyond the scope of an aide. But could they take that hot pack after the therapist or the assistant is done and put it away? If they've been instructed how to put it in appropriately so that it doesn't explode, the appropriate temperature of the unit that it needs to be maintained at, then maybe could they participate in that piece of it? So you really have to be considerate that you're not stepping into any decision making with the tasks these individuals are completing. Other assistive personnel that possess some type of license or certification, they've received some type of formalized training. So as I mentioned, exercise physiologists, athletic trainers, massage therapists, they can be delegated tasks by the physical therapist. The physical therapist has to provide on-site supervision. And you have to consider the additional piece that the tasks that you're delegating to those individuals, you need to make sure as the PT that what you're delegating is within the scope of practice. So if you are having the massage therapist perform the massage on the patient and then you're coming back in after the tissue is warmed up, the trigger points are released, and then you're doing a stretching, that theoretically is within the scope of practice of that individual, assuming they are actually licensed or certified in the state of Tennessee the way they appropriately should be. You'd have to look into that. And additionally, you need to co-sign all of the documentation and patient records that that other practitioner is providing. On-site supervision for these individuals by definition means that the PT and the PTA are continuously on site and present in the facility, in the department. So there's not, walls in between. You're not behind closed treatment doors, because you need to be immediately available to assist the person that's being supervised. And you are additionally maintaining continued involvement in that patient's session. It's not like you're handing them off and you're done. For that period of time, you're still involved in that patient's care. The ratios are specific that can be utilized for supervision. PTs are able to supervise a maximum of 3 physical therapist assistants and then 2 aides or assistive personnel. And then a PTA is able to supervise 2 aides. When we look at the individual that's being supervised, the terminology that they utilize when they say, 3 PTAs, it's the equivalent of a full-time person when you're looking at it. So let's say you have one PTA that works the morning, one PTA that works the afternoon. You can supervise, they may be 2 different people, but it's one position to meet the full-time equivalent. So that would be okay if you had different split days that way. When we consider other individuals that might physically be in the clinic, those would be our volunteers. Tennessee specifically defines volunteers as individuals contemplating a career in physical therapy. So that is the one and only definition that's in there under the PT Practice Act and rules related to a volunteer. So someone who is truly in an only observational capacity. They can be direct on-site supervision, but they're not doing anything to supervise, but you have to make sure of that. And that can be completed by the PT or the PTA. Students can be permitted in the clinical environment as long as they're an active student and they're there on a clinical rotation associated with a CAPD accredited program. The clinician who's supervising must have 1 year of experience, and that's in line with CAPD regulations and guidelines. And PTs are able to supervise PT students as well as PTA students, and then PTAs are able to only supervise PTA students. Home health aid supervision, they put out a policy statement on this, so something must have come up. I was trying to brainstorm an instance where this may come up. Maybe if you're in home care, the policy statement says that supervising home health aides is not in itself a violation of practice and rules to supervise them if no other ethical or practice violations are present. So you're able to supervise them as long as you're not in violation of anything else. So I'm guessing there must be really specific situations that arise related to that. I couldn't think of any, but make sure you know that this is the regulation if it was ever to come up for you. Let's look at a case study related to supervision. Following evaluation of a patient with adhesive capsulitis in June, the PT delegated treatment to the physical therapist assistant. The established plan of care for stretching, therapeutic exercise, modalities, and functional training was followed 3 times a week through New Year's Day. Other than August, when the PT reevaluated the patient, the PTA completed assessments and monthly status reports to the physician, where supervision requirements met. Something to consider as you are deciding if the supervision was appropriate. The PT must reevaluate every 30 days and actually perform observations every 60 days. And PTs and PTAs are equally responsible for care, and clinicians have to practice within their scope. So given that refresh, were we within the supervision requirements? No. For several different reasons. First off, when we go from June to January, that was 7 months. In that time period, there should have been 7 reevaluations by the physical therapist, counting every 30 days. That didn't happen, and there should have been several observations of treatment, none of which happened. So there was that failure to observe. I actually found this as an actual case where there was disciplinary action, and what they cited for the physical therapist was inadequate supervision, failure to observe and reevaluate. The individual had a PT 1 year of probation, $2,000 in fines assessed, and they had to complete 50 hours of continuing education in ethics, jurisprudence, documentation, as well as supervision. The PTA, because equally accountable, the PTA was actually found of practicing beyond their scope of practice and providing substandard care, because by not having the physical therapist involved, the patient was deprived of the physical therapist services. They also exceeded their authority to perform, and they were given 1 year probation, and they had to have quarterly reports completed from multiple supervisors, and then the 15 hours of continuing education also. So both parties were found accountable in this instance. Some more questions to look at. Number 17. Which of the following is true regarding Tennessee physical therapy supervision requirements? Number 17 is C. 17 is C. Number 18. Which of the following statements is false when practicing physical therapy in Tennessee? Number 18 is A. 18 is A. When we consider disciplinary actions, there are several different types of disciplinary actions that can be taken and actions that lead to consequences and violations. You're actually able to go in and search the practitioner license in several different databases to see if there are any violations against the practitioner. When you think you might need to do this is definitely if you're a supervisor, if you're a hiring manager, you may be involved in this role. If you consider the ethics related to situations and the fact that when we talk about some of the disciplinary actions, just having knowledge of information could lead to disciplinary action if you don't act upon it. There might be instances that come up where you want to verify someone's license, search the abuse registry to see if there are any violations against the person. I want you to note that in Tennessee, that individuals who fail to pay their child support can have their physical therapy or physical therapist assistance license to practice suspended. Same thing if individuals are defaulting on their student loans. The different types of disciplinary action that can be taken by the Board of Physical Therapy, they're going to base it on the offense that occurs. They may suspend or revoke license, place someone on probation. Civil penalties are when they are assessing a fine for the individual. It's not a fee that has to occur, it's a civil penalty. So it's a fine for the action that they took that was inappropriate. And then they leave it open for themselves that any other action that they deem appropriate, they can require of the licensee. So these might be things like continuing education, additional supervision, or anything else they determine. Offenses that may lead to disciplinary actions. I made my own categories for these as I looked at the list and the different rules and statutes. I just tried to group them. So these titles are my own titles that help you see it a little more. When we look at patient care, obviously practicing outside of the scope of practice, failing to maintain those appropriate patient records, inadequate supervision, as well as aiding and abetting a person who is not licensed who directly or indirectly performs activities. This is, remember those situations we said under the ethical, do you bring it up, don't you bring it up, how do you know if you should, and you have that struggle? Right here, sometimes the law makes the decision for you, that you may have just that legal obligation to bring it up. And remember that we need to understand all the laws in order to take the appropriate action or know when a situation is illegal and something's being violated. When we look at substandard care, it's important to recognize that substandard care, I think the case study we looked at is an eye-opener related to that description. The PTA, by exceeding delegated tasks, so they may think, well, I'm doing more for my patient, this is okay. It actually works the other way. If you exceed and go outside of your scope, you are depriving the patient of that physical therapist role, so you're actually delivering substandard care. The physical therapist, if they are not the appropriate individual or they are not skilled or sufficiently knowledgeable in something to be performing it through incompetence, ignorant, or deliberate neglect, that is considered substandard care. If you're doing treatments that just aren't necessary, also consider if you're doing treatments after they're done being necessary. So that patient that you're like, oh, you know, they're lonely, I'll just stay a little bit longer to do their exercises with them, or let them come in the clinic and do some more exercises. You really need to consider if it's beyond the benefit and you're rendering services that you're falling outside of the letter of the law. There may be different situations where that occurs. Overutilization of appropriate interventions. If an intervention is indicated, but you're utilizing it too much, too frequently, for too long. And then this one I found interesting, that abandoning patient care without informing them of other options. You have to consider that when patients are discharged from therapy, we're discharging them. That's a plan, that's a discussion, that's a consultation we have. But if you just abandon them, if you maybe, and this is just me guessing how the board might consider this. Let's say someone who constantly is late or they miss therapy sessions, and your policy is that they're discharged from therapy because they continue to not show up. Well, in that case, could it be deemed that you've abandoned them? So maybe you need to have a piece in that policy that you also give them other referral options, or you explain to them, you know, in the beginning what the sequence of events would be. Again, just different ways to try and think about this. And always contact the board if you have any questions. Looking at fraud, any misrepresentations, inappropriate charging, where you may be getting any type of kickbacks or fee splitting. They specifically say you cannot accept gratuities in any way, shape, or form. That we discussed this during ethics also. No type of fee splitting can be occurring. Looking at criminal histories, it's important that if once someone is licensed, something comes up where there is any type of felony offense related to moral turpitude is the terminology. So this is any conviction or adjudication of any misdemeanor that involves sex, drugs, physical injury, or a threat to injury to a person, abuse, neglect, and the populations there are minors, spouse, or elderly. If there's anything related to fraud, these things need to be reported, and then there may be additional disciplinary action against the individual's license. One example here would be a DUI that the individual would need to report. You need to be aware of your patients. If you have any suspect that an individual or patient in your care is the victim of any type of neglect or abuse, you need to report that to either Child Protective Services or Adult Protective Services. And other populations that are protected are individuals with disabilities or the elderly. So bear that in mind in your reporting end. Looking at competence, if you as an individual are impaired in any way or incompetent is under a judgment. If you have a license in multiple states, and in one state there's a disciplinary action and you're like, oh, I won't deal with that, I'll just go to this other state. No, it doesn't work that way. You need to report that. In any state, it could compromise your license. And then failure to meet the continuing competence requirement. Looking at actual conduct, offenses that may lead, any sexual misconduct is inappropriate. We've discussed that already. Just engaging in any type of sexual communication, verbal, written, text, in any way at all with patients is a violation. Something that was in here is intentionally viewing completely or partially a disrobed patient if it is not related to patient care. They actually have that in writing. Shocking they have to say it, but I guess they need to. We all know that failing to adhere to ethics, or as I mentioned, that failure to report violations of others, and we need to maintain our patient confidentiality. We'll look at a couple of more test questions. Number 19. Which of the following is an offense that may lead to disciplinary action by the Board of Physical Therapy? And number 19 is D. 19 is D. Number 20. What is the term for the type of disciplinary action imposed by the Board of Physical Therapy practice that requires the payment of a fine? And number 20 is B. 20 is B. That concludes our presentation on ethics and jurisprudence for physical therapy in Tennessee. Hopefully you have additional clarification or just confirmation of what you already knew about the ethics and laws and rules of the state so that you can continue to provide quality of care and maintain your integrity in practice. CEUs for this course, what you want to do is go back to cheapceus.com where you initially accessed this presentation. You're going to scroll down to this specific course, and to the right, click on Take the Course Post-Test link. You'll complete the post-test as many times as you need to so that you achieve that score of 80% or higher, no penalty for retakes. Once you achieve that 80%, then you're going to submit your payment and print your certificate, and your CEUs will be completed. I appreciate you attending this course with me. I hope you enjoyed the content as well as the delivery format. Look forward to maybe seeing you again in one of the courses, and I hope you enjoy the rest of your day.